Good morning, everyone. As everyone is slowly trickling in, I think we will get started, Dr. Bovee, so we can start our first speaker on time at 8 a.m.
Sounds good.
All right. Good morning, everyone. I'm Huade. I'm one of the co-chair of the symposium, and it is my great pleasure to welcome you to the 6th Annual Wisconsin Primary CNS Malignancy Symposium. This meeting represents a continued collaboration between UW-Madison, MCW, and ThetaCare, grounded in our shared commitment to advancing care for patients with brain tumor across Wisconsin and beyond. This year, we turn our focus on rapidly evolving role of artificial intelligence in neuro-oncology. From augmenting diagnostic precision in neuroimaging and pathology to informing surgical planning, predicting treatment response, and enabling more personalized clinical decision-making, AI is reshaping how we approach complex brain tumors. Importantly, this transformation is not limited to clinicians. Recent surveys suggest that nearly 1 in 4 individuals are already using AI tools to seek health advice. This underscores a parallel shift in how patients' usage with medical information, raising critical questions about accuracy, trust, equity, and how we as clinicians guide our partner with increasingly informed and sometimes misinformed patients. Our goal with this symposium is to equip clinicians, researchers, and trainees with a deeper understanding of how AI can be meaningful and ethically applied to improve outcome of patients with primary CNS malignancy. Through interdisciplinary dialogue and exposure to cutting-edge innovation, we hope to accelerate progress while continuing to train the next generation of leaders in neuro-oncology. Dr. Bovee?
Thank you so much, Dr. Day, for that outstanding introduction and also for your leadership in continuing to bring this conference to life. I'd like to call out a couple other members of our conference leadership team. Dr. Max Krukoff is joining us from Milwaukee, Wisconsin, where he's a neurosurgeon there at Fredericton Medical College, Wisconsin. And then also Dr. Brett Morris is on the line as well, and he is a radiation oncologist at UW-Madison. And the 4 of us have had the pleasure of putting this conference together, and we're really excited to hear our panel of speakers this morning. It really is truly remarkable that we're now gathering for what is the 6th annual Wisconsin Primary Central Nervous System Malignancy Symposium. And really, it's that kind of consistency and growth that reflects a shared commitment across our institutions for advancing care for patients with brain tumors in the state of Wisconsin. This year's focus, Transforming Brain Tumor Care with AI, really captures the moment we're in as a field. Today's program brings together an exceptional group of thought leaders spanning AI in healthcare: imaging, computational neurosurgery, pathology, genomics, and clinical decision-making. I also want to extend a sincere thank you to everyone behind the scenes who made today possible as well, especially for Janelle for her outstanding coordination, our IT team, Caleb, for ensuring a seamless virtual experience for us this morning. And finally, thank you to all of you who are on as both our panelists in addition to our attendees, for being here and for your commitment to this work. We're really looking forward to a fantastic and impactful session ahead. And with that, we'll move on to our first speaker.
Thank you, Dr. Bovee. And it is my great pleasure to introduce Dr. Poon. He's a general manager and distinguished scientist at Microsoft Research, where he leads efforts in biomedical AI and health intelligence. Dr. Poon's work focuses on advancing artificial intelligence to transform healthcare, with particular expertise in natural language processing, large-scale knowledge system, and clinical data integration. His transformative research has driven the development of AI tools that extract and synthesize insights from vast biomedical literature and real-world clinical data to support decision-making and accelerate discovery. Today, he will discuss Towards Virtual Patient, AI for Accelerating Medical Discovery. Welcome, Dr. Poon.
Thanks so much. Can everyone hear me okay?
Yes.
Sure can.
Awesome. Let me try to share the screen. It's a great pleasure for me to attend this. So thank you so much for the invite. Can you guys see the slide?
Yes.
Awesome. It's really wonderful to be here, and I will try to share some of our journey in the past decade and a half at Microsoft Research, where we are exploring how AI can potentially be used to help accelerate medical discovery. Um, so, um, I want to basically show you three kind of new capability that AI can potentially empower medical scientists going forward in medical discovery. The first one is really sort of like empowering medical scientists to really see much better because there is a lot of biomedical data that have really elaborate kind of patterns and so forth, right? AI can potentially uncover, help human expert to discern those complex patterns. And then the second capability is really sort of like kind of a crystal ball, right? Because ultimately the moonshot for precision health is to be able to accurately start to forecast what would be disease progression, and thereby what if we take on certain intervention, what might happen. And if we have that kind of crystal ball, it will be very helpful, and AI start to be able to kind of like create that kind of more and more accurate crystal ball. And finally, it's a really sort of like a wind tunnel, right? AI will start to be able to enable us to actually simulate experiments, right? To conduct experiment in silico. From a technical point of view, in a nutshell, sort of like our entire research program can be summarized by a single sentence, which is learning the language of patients. So imagine a cancer patient coming in, initially, often we have a non-invasive radiology, information such as CT, MRI. Then after biopsy or resection, then you might get digital pathology, multi-omics, and so forth. So each modality is trying to tell us something about the patient. But if we don't understand the language, then they just sound like gobbledygook, right? On the other hand, if we can start to master this kind of multimodal language, then we will be able to start building kind of like virtual patient world model that will be able to serve as a patient digital twin. So the trillion-dollar question then is that can AI deliver? So there is obviously a lot of hype, and there is also some natural skepticism. And I personally find it very useful to think about the application of AI actually spanning a spectrum from essentially what I would loosely call productivity gain all the way to creativity gain, right? So essentially from automating mundane chores that human could perfectly do, but just very tedious, very time-consuming, expensive, and all the way to actually arguably even the best human expert are struggling to do to be able to automate discovery, to see patterns that naked human eyes are very difficult to see. And here, actually, there are this Mara's law that observe that we tend to overestimate the short-term progress, which often lead to the hype, right? So, for example, we are still quite far away from automating discovery all the way, but we also, in the same time, we also tend to underestimate the long-term progress, even though major transformation are already happening. And in biomedicine, and right now, actually, major transformation is already quietly happening on the left-hand side on the productivity gain. So in the remainder of the talk, I will basically share a few examples, starting from productivity gain all the way to creativity gain. As you all know, medical discovery essentially runs one clinical trial at a time. This process is largely manual and extremely inefficient. So for example, a single phase 3 trial can take years to execute and often cost $100 million or more, right? And despite all these substantial resources, actually, at the end of the day, you still get only relatively limited information from a small sample size. So in collaboration with Providence Health, which is the third largest health system, nonprofit health system in the US, we developed this AI called ChildScope that can enable medical scientists to utilize real-world patient journey and be able to simulate, sort of like conduct clinical trial virtually and end-to-end from the unstructured electronic medical health records. So with our Providence collaborators using Providence real-world patient data, we demonstrate that this kind of virtual trial can be just as accurate as a real one by comparing to the gold standard trial for marquee cancer treatment. So for example, Keynote-10 here is one of the original trial for Keytruda, one of the best-in-class immunotherapy. And obviously, virtual trial can be much cheaper and faster to conduct than real one. Now, of course, AI is no magic, right? So all this actually can happen because we are already routinely collecting lots and lots of data points that document patient journey from diagnosis to treatment to outcome, and exactly the kind of patient journey you will study in a clinical trial. And one of the barrier, of course, in the past is that, this kind of data is primarily using for billing and operation, right? But if we can using AI to start to unlock the insight underneath, then this becomes essentially the population scale pretty much. However, this kind of data tend to be highly unstructured. So for example, cancer patient may have hundreds of nodes, right? But frontier AI already advanced to such a state that it can already enable medical scientists to structure all this data with high accuracy and at scale. So every year there are 20 million new cancer patients in the globe, and traditionally manual abstraction can take hours and cost hundreds of dollars per patient. But with frontier AI power universal abstraction, it takes seconds and costs a few cents. So for example, at Providence, every night after the data backup from the live system to the data lake, our ChildScope AI agent basically woke up at 1 a.m., process all the incoming nodes and start to extracting all these fine-grained medical events, right, that can, be relevant to the clinical trial eligibility. And in this way, we can essentially kind of like monitor the patient and the trial in real time and identify precisely the short window of opportunity where the patient satisfies all the criteria and also before the first disqualifying event kicks in. So obviously, with this kind of technological capability, we can also start to reimagine the entire clinical trial process, right? There is a lot of kind of step right now that can be completely rethink and so forth. And also personally, one of the particularly exciting prospect is that this can potentially help supercharge health equity. So in the US, 85% of cancer patients are treated in community center or rural hospital. And due to resource constraints, traditionally they are largely excluded from a lot of this clinical trial. But now we can potentially using technology to level the playing field and ensuring those patients have actually a chance to be considered for potential, life-saving kind of last hope, and also potentially dramatically speed up the clinical trial process. And so far you have seen sort of like one marquee example on the productivity gain, which is already quite exciting. But in the grand scheme of things, this is really just an appetizer, right? So all those clinical texts, they are really a highly imperfect human translation of patient ground truth. So a lot of those kind of like medical imaging, they contain highly elaborate kind of like patterns, right? So over the years, I start making a lot of friends with medical folks, and they start to tell me a lot of jokes, right? So radiologists will tell me sometimes they may not even agree with themselves after a couple of weeks seeing the same image, and pathologists will tell me that sometimes they turn a slide 90 degrees and begin to see different things. Now, obviously, these are among the smartest people in the world. But the challenge is like our visual cortex are do not really evolve in the jungle reading MRIs, right? So, but AI can now potentially help them to begin to see them much better as sort of like providing the new microscope, right? And also another really important point is like any kind of like modality, no matter how high value they are, they really have their own limitations. So we really need to synthesize all the modality to recapitulate a holistic patient. So this really sort of motivate us to think about sort of like precision health from a machine learning point of view as essentially trying to learning a function that input the multimodal input and then be able to try to predict two really important medical events, how the disease will progress and what will be the counterfactual tumor response. And now the challenge is like the patient journey is really not a snapshot, but really a longitudinal time series. And most frustratingly, most of the information we care about actually are missing. And even the observable information can be, noisy and biased and so forth. But this is exactly why Gen AI can be so promising for precision health, because the Gen AI signified generative models. Basically, the idea is that we try to estimate the joint probability distribution among all the relevant clinical variables. So this sounds like we actually sign up for a much harder job, but if we can even make modest degrees of success, we will be able to attain a principled way to kind of like model all those uncertainty, noise, and biases. And we will also be able to compress all those observed information into a compact embedding, and also be able to infer reason about those missing information in a principled way using probabilistic inference. And then predicting the future event is really just a special case. So this sort of really motivates us to kind of like think about a research agenda that's central on portraying powerful frontier biomedical models using real-world data. And the Gen AI disruption means that for the first time ever, we will now potentially be able to create a high-fidelity biomedical forward model that can serve as a digital twin for the patient. And with such a high-fidelity virtual patient at test time, we can actually conduct patient-like reasoning at the population scale. So when somebody have a cancer diagnosis today, if they have resource, the first thing they are going to do is to get a second opinion. If we have such a virtual patient, we can actually snap a finger and conjure up a million second opinion from the most similar patient, look at what have been done to them and what are the longitudinal outcome, and potentially help improve patient care. We can also compare non-responder and exceptional responder at the population scale and begin to understand why those drug doesn't work on some patient, but actually can cure other patients, right? So even the best doctor cannot really internalize 8 billion patients' journey, but AI can potentially help them to do exactly that. So of course, this is quite exciting agenda, but there was many challenges. And one of the fundamental limitation for kind of rate limiting factor for AI and particular machine learning is that traditional machine learning require that you basically teaching how the AI model should behave, right? So you have to painstakingly create this pairs of input-output examples, and that become sort of like really a major bottleneck. So over the years, a lot of our research focus is actually entirely focused on how can we identify a lot of the readily available data that might be relevant to the problem that you care about, and using sort of like AI and ingenuity to be able to kind of like convert them into potential signal to compensate for the lack of those input-output examples. And so you can think about this as essentially getting free lunch from those readily available kind of information sources, right? So in particular, I will show you 4 recipes of free lunch. The first recipe is really like any moment you have an annotated data point, you can turn them into a so-called self-supervised training instance. And for example, here is one particular powerful paradigm where you introduce a modality. For each modality, you introduce a modality-specific pair of encoder-decoder, right? And then a big chunk of machine learning is really just a glorified dimension reduction, right? So, for example, you really want to reduce gigapixel, a billion dimension in a digital pathology slide to maybe a 500 dimension vector representation so that you can learn from them much easier. So encoder is exactly doing that kind of non-linear kind of dimension reduction. But you also want to make sure that they don't put arbitrary crap into the embedding. So that's where the decoder come in, where you're forcing it to be able to create from this compact representation and try to as accurate as possible to reproduce original input. And the text modality, on the other hand, is very, very special from all the other non-text modality because Frontier are already doing very, very well there. Partially because there is a lot of biomedical text, even clinical text in the web, right? But on the other hand, there isn't that many multimodal longitudinal patient journey in the public web. So and that's where the Frontier AI is lacking, and where we try to actually bridge all those competency gap. So this paradigm is very powerful, but for individual modality, there are also a lot of idiosyncratic challenges. And so, for example, immunotherapy is probably among the most promising direction for taming cancer once and for all, given that immune system is the one health system that can really counter the natural selection for cancer mutation and relapse, right? But the best of in class immunotherapies right now still the response rate is still far too low, and it's well known that the tumor microenvironment is really holding a lot of secrets by actually showcasing how the tumor cell, immune cell, stromal elements that actually are situated with each other. So behind the scene, there is almost basically like a tumor microenvironment grammar behind the scene that govern whether the cancer might be able to kind of respond to the immunotherapy or not. It's just that this kind of grammar is very elaborate, very hard for just naked eye to try to unravel. So arguably, we have exactly the right tool. For example, one of the workhorse for modern Gen AI is Transformer. For imaging, right, how Transformer works is essentially trying to pass message between every 2 pixels. And then all those deep learning multi-layers is essentially enabled this kind of message passing for many rounds so that every pixel know everything about the other pixel. This is exactly why Transformer can actually encode arbitrarily complex global patterns. But the challenge is that this also bring up a curious hue for Transformer, because in order to do that kind of pairwise message passing, you incur computation that will be quadratic in the input size. And pathology is some of the largest image in the world, right? So a single pathology slide using standard Transformer can cost you 1 billion times of compute compared to your favorite cat and dog images, right? So we basically borrow an idea that originates from speech recognition called dilated attention and adapt that to digital pathology. So the whole idea is like for a small neighborhood, it's perfectly fine to do that pairwise message passing. And after you do that, every pixel already know the neighbor. So that when we actually try to pass message from a local neighborhood to the faraway neighborhood, which is when Transformer traditionally explode, right? What we can do is to elect representative for each neighborhood and then focus the message passing between the representative. So in this way, we can basically substantially cut down the computation, but still maintain the bulk of the fidelity of the information. So we are very lucky to have wonderful collaborators at Providence and University of Washington. We developed this model called GigaPath that is really the first pathology foundation model that can truly scale Transformer to the gigapixel whole size images. And we published this in Nature. And one of the really kind of like really exciting prospect is that this basically enable us to uncover some of the pan-cancer signature from the HAE pathology slide to predict some of the really important biomarker across actually 31 different cancer types. And then Mount Sinai and Memorial Sloan researcher basically take this model and then demonstrate in a global prospective trial that actually they can use it in real-world clinical deployment. So even in the US, a quarter of the lung cancer patient never get the EGFR mutation sequence before the first line, and so thereby due to resource constraint, so those patients likely didn't get the optimal treatment, right? But this researcher basically demonstrated that they can using GigaPath, and the moment you get the tissue sample, take the microscopic image, and you can predict the EGFR mutation status fairly accurately to use that for precision oncology triaging. So overall, the GigaPath model have been downloaded for millions of times and across the globe. Very, very exciting for us. So this is sort of the first kind of like example of the kind of first free lunch, right? But imagine tomorrow you woke up, you have already trained kind of like really good foundation model for each modality, right? That's still far from being enough because there is no guarantee that the semantic space for those modality will actually align, right? So in this sense, each modality is kind of like a distinct language. So CT could be a French and digital pathology could be a Hindu, and very soon you have a United Nations problem. So in actual machine translation, what people do is to introduce a resource-rich language, typically English, right, as to serve as in so-called interlingua and a bridge. So now you can basically translate across many languages by first translate language A into English, and then translate from English to language B, right? So this is exactly how commercial translation engines scale to hundreds of languages in the world. So we propose to basically take this playbook and apply that to multimodal reasoning in biomedicine. And one of the obvious kind of like candidate for interlingual modality would be text, because we already have very powerful frontier model for them. This kind of text frontier model, and also for any modality under the sun, we often have some of the paper trail, right? So radiology image, you sometimes have the report, pathology slide, you sometimes have the pathology report. So then we can reuse all those encoder, decoder, focusing our computation on training a relatively lightweight adapter that can essentially serve as a translator to ground each modality to the text modality. So now all of a sudden you pull all those modalities closer together, and also you harness the already sort of very high competency of this kind of frontier model in actually capturing the human knowledge in the text, and also the reasoning capability to using that to interpret individual modality. This paradigm has been used for many applications, and here I will just give you one example where essentially using the natural language interface to produce this model called Biomed Parse, so that you can enable medical scientists to simply talk to the image and conduct holistic image analysis, right? So Biomed Parse really captured a lot of the major medical imaging modalities. It was published in Nature Method, and the Nature Method editor got so excited that she also published an independent review that says some encouraging words about this work. It's also always really exciting to see some of the community actually find this kind of model useful. So far we talk about modalities that are relatively abundant, right? But in biomedicine, there are also tend to be a long tail of kind of like high value modality that are nevertheless very, very scarce, right? So for example, spatial proteomics is one of the really exciting frontier where you can actually simultaneously measure multiple protein activation in individual cells, right? And thereby provide really a very detailed digital map for the tumor microenvironment. The challenge is that this kind of data is very difficult and expensive to generate. So generate data for a single tissue can take days and cost thousands of dollars, and generate data for everyone in the globe will bankrupt humanity. So in collaboration with Providence and University of Washington, we developed this multi-modal AI called GigaTime that essentially start from a Rosetta Stone of 40 million cell with pair H&E pathology slide and the spatial proteomic information, and then train a translator that can start to simulate from the H&E pathology slide to the spatial proteomics. So here in this example, you can see the ground truth in the middle column and then the simulated in the right. So again, AI is no magic. We are not going to get perfect anytime soon, but nevertheless, this will still be able to kind of like already shows quite a bit of promise of actually capturing quite a bit of information in the spatial omics. So obviously behind the scene, there is no magic, right? So what happened is that actually date back to this very old idea called distributional hypothesis that can date back to the dawn of AI and linguistics. So basically imagining you woke up and seeing a part of Martian text, you don't understand any words in it, right? But you notice that for a pair of words, A and B, right, they often appear in the context of same words. And that's actually can be sufficient ground to start hypothesizing maybe these two words have related meanings. Maybe they're synonym, maybe they're antonyms and so forth, right? So, and that's actually exactly the intuition behind word embedding, which also behind the language model and ultimately to all the LLM and GenAI revolution. What's exciting is that this actually seems to also be potentially applicable to cell biology. So, for example, when you look at the 2 T cell, it's very hard to tell whether they're active or exhausted, right? But active T cell tend to appear in the environment that are supportive, whereas exhausting T cell tend to happen in highly regulated environment. So by essentially just make out some of the rough morphologies and coarse cell type in the surrounding environment, we might be able to using that to kind of start to infer the cell state. And just like in language, obviously this is far from being perfect, but still they can actually allow us to go pretty far. So what this enables us is that we can now start to take all the H&E, right, begin to simulate the spatial proteomic information, and then start to using that to correlate with downstream information like, disease progression, tumor response. And thereby enable sort of like very large scale spatial proteomic study that were previously completely unthinkable. So finally, I will give you sort of like the last and perhaps the most important kind of like free lunch, which is the patient journey themselves. So many of you are probably familiar with how GPT-4 learn by predict next word, right? So similarly, virtual patient can potentially learn by serializing a patient journey and then learn by predicting next medical event, and so forth. Now, the really important key is that you can't do this for a few kind of journey, then nothing much happens, right? But if you can imagine portraying on 8 billion patients journey, then we can start to get into the so-called emerging capability regime, which is what people observe in the large language model, right? So it's like if you have sort of like train on large enough data, then you can start to be able to get the model to actually suddenly get to a very intelligent state. So we are quite excited to take a baby step collaborating with Epic and Yale, portraying this curiosity model. It was building on top of the fantastic work that Epic Cosmos community have essentially harmonized a 300 million structured patient journey, right? And with that, we were able to train essentially the largest virtual patient model in the world right now from over 100 billion medical events. And to support this, obviously we can't do sort of like this kind of scale, unprecedented scale of pre-training. We need to know what we are doing, right? So we actually conduct this so-called scaling law study by starting from small scale pre-training, smaller models, right? To establish best practice and also to demonstrate that actually by scaling up the pre-training, we can actually dramatically improve the predictive accuracy for predicting next medical events, and thereby hopefully also be able to attain higher and higher accuracy in downstream tasks. So obviously this is still a tiny baby step, but we already see some promise. This curiosity model were able to actually out of the box by simulation future events alone, right? We were able to kind of match and outperform supervised method that's specifically designed for individual tasks for 78 clinical tasks. This was announced in the user group meeting by Epic last August and start to roll out to Cosmos users. So, and to conclude, I present to you sort of like three kind of like new capability that AI can potentially empower medical scientists to drastically accelerate this medical discovery towards precision health. And one big caveat, obviously, is that, again, AI is no magic, and also real-world data, one of the key challenge is that they are observational data, so thereby there could be lots of confounders. But here is also an area where potentially a virtual patient AI model can help us model those distribution better and account for those unknown confounders and actually adjust for them much better. So I want to acknowledge the team and also our wonderful collaborators. Thank you.
Thank you, Dr. Poon. That was a great talk, and we learned quite a bit. We'll save the questions for our panel discussion towards the end, so we can stay on time. Our next speaker, I would love to invite Dr. Dan Oringer, a neurosurgeon and associate professor at NYU. Dr. Oringer's work sits at the forefront of innovation in neurosurgical oncology, with a focus on integrating advanced imaging and artificial intelligence in the operating room. He's widely recognized for pioneering simulated Raman histology, a technology that enables real-time intraoperative tissue diagnosis, and for developing machine learning approaches to enhance surgical precision and decision-making. His research brings engineering, computer science, and neurosurgery to improve the safety and effectiveness of brain tumor surgery. Today, he will be discussing the utility and limitation of intraoperative AI-assisted histology in brain tumor surgery. Dr. Oringer.
Thanks, Dr. Day. It's a pleasure to be able to participate in this symposium. I'm sorry about all of the logistic chaos leading up to this. I'm going to go ahead and share my presentation, foresight and intelligence of the students that we've had in the lab. And so what I wanted to touch base with you on today is the way that we're applying artificial intelligence among other technologies to close some of the gaps that we have in brain tumor surgery. So, I think because this is a brain tumor talk, so the first message, and this is something just to sort of lay the groundwork here, is that we know from so many high quality studies that have popped up in the last 20 years or so, that what we do as surgeons is so important as the cornerstone of the disease, the treatment of CNS malignancies. And by no means is it everything, but it really can change the course of how patients do over time, among other things. And it's one of the things that we have in our hands as surgeons, and we need to be able to move patients between these survival curves that we see for low-grade gliomas and for high-grade gliomas. We don't want patients left in a situation where unresectable tumor is left behind after our surgical intervention. We want to be able to put them on the curve that gives them the longest overall survival. And that means making sure that we get out as much tumor as safely possible. The interesting thing, though, is that optimal surgical results are achieved in a minority of cases. If you look back at this paper that we published in 2012, amongst tumors that were felt to be completely resectable, these were IDH wild type GBM tumors. And we identified a subset of patients that there was a consensus on resectability, and found that complete resection was achieved in only 23.5% of those patients. That was a paper that we published in Journal of Neurosurgery in 2012. And then updated low-grade data we can see from Sean Hervey-Jumper's 2023 JCO paper that shows that near total or total resection is only achieved in about half of patients or less amongst diffuse low-grade gliomas. And why is that? And part of the reason that occurs is because there's a great disconnect between what we see with our eyes in the operating room, what we see macroscopically, and the actual definition of the disease, which happens on a genetic level, so at the level of the base pair. So there's a great disconnect between what we perceive at the macroscopic level and what's actually happening at the genetic level. There are various classes of intraoperative imaging that have been developed that address this issue, and there are different technologies that take us down from the macroscopic, like intraoperative MRI that images on the whole organ level, Our eyes allow us a resolution of about 0.2 millimeters to see tumor, and we can sometimes see major distinction between tumor and adjacent brain. Our loops improve our resolution dramatically, operating microscope down to 0.1 millimeter. But there's still a big gap between what we can see with our eyes and our microscopes and what's happening on a histologic level. And so we developed technology that would allow us to have submicron resolution to see histologic details. And that is enabled in part through artificial intelligence and optics. And in part through an increasing understanding of the molecular world that lies below. And we have technology that I'll touch on a little bit today that looks at brain tumors where they actually exist, which is on a molecular level. So just going back one slide, the ground that I'm intending to cover in the next couple of minutes basically takes us from where we were before. Sorry, some technical difficulties here. Seeing things on a macroscopic level, applying technology, in this case, stimulated Raman histology, which is an optical technology that we developed back around 2008, 2009, and translating that into clinical use and ultimately augmenting it with additional wet lab technologies. So what is stimulated Raman scattering microscopy? It's best understood by an analogy, just as MRI gives us a distribution of the small molecules that make up biological tissues, a distribution of water. Stimulated Raman histology is basically using an optical technique to map out the distribution of proteins and lipids within cells. The development of this technique, led by my colleague, Dr. Chris Freudiger, during his PhD thesis, was a real breakthrough. This paper has been cited over 2,500 times. And what's amazing about it is that it's a label-free microscopy, a label-free medical imaging technology like MRI that allows us to get histologic images without taking the tissue out of the patient, without having to apply any external labels or dyes, because the molecules that are generating contrast are intrinsic to the tissue. And I met Chris at a meeting back in 2009, I believe it was. And, he told me about his work, his PhD thesis, and I thought that would be great to apply to brain tumors. And he was looking for an application of his technology. So we collaborated and applied an animal model that we had been developing in the lab called the cranial window model to recapitulate that challenge that I mentioned before, where it can be challenging to differentiate between tumor and normal brain. We applied this technique, and we can see that this is a blue-green type of lookup scheme, but in this normal appearing cortical surface, there's tumor that lies immediately beneath the surface. And we use this imaging modality to be able to differentiate between the normal and the abnormal and the interface between. You can actually see individual tumor cells snaking into this cortex. And so we felt like this technology would be quite powerful. We rapidly, by rapidly, I mean over the course of years, translated this for human use. And going beyond the animal models, we sent tissue specimens from the very early days of my surgical practice at the University of Michigan to the basement lab in Harvard, where this technology was developed, and realized that we could see that tumor-brain interface that's present in human brain tumor specimens as well. Chris developed this platform for making that microscopy technique portable and shipped one of these things to my operating room. This is a Mott Children's Hospital at the University of Michigan, where we did this imaging technology for the first time. Chris built this thing in California, put it into a shipping crate, put it on a plane and truck, and it ended up in my OR, which was like one of the coolest things that's ever happened in my life. And then another cool thing was my student, Balaji Pandian, came into my office one day after we had talked a little bit about this technology and had a vision for not just how to make these images more interpretable, which is what we're showing here, instead of this blue-green lookup table that created something that looked more like a lab-based imaging method, we're able to apply the protein and lipid distribution to an H&E type lookup table to create virtual histologic images that you'll see throughout the talk. So it looks more like the pink purple that we're used to seeing. Balaji also, he was a computer science student at Harvard. He graduated from Harvard in like 2014 and came into my lab shortly thereafter when he started as a medical student. And he said to me, you know, we should really start applying artificial intelligence to this. And I thought that sounded so alien back then, and it did. It was the first I had heard of it, but he had a vision for how we could apply artificial intelligence to the interpretation of these images. And what I realized was that, you know, the images were, I guess I should say, my mentors told me from the time that I was doing that work at Harvard that we really needed to quantify the images. And I knew that on some scale, but what artificial intelligence allowed us to do was to bring the diagnostic information that's in these images out. And initially, you know, we could see that all of these structural histologic features that are required for neuropathology and diagnosis are there. We see all the features that we need to see, all the features that we look at in tumor board every week. But making these images accessible, as neurosurgeons in the operating room, we don't have time to review histologic images, and it's not a core part of the training of neurosurgeons to be able to diagnose brain tumors histologically. We get a peripheral understanding of it, but we don't have the familiarity that our colleagues do. But it's so important for our the way that we take care of patients. So to improve the accessibility of stimulated Raman histology images, Balaji and my student at the time, Todd Holland, developed this pipeline where we went from fresh tissue that was put into this imaging modality that Chris developed and sent to our operating room. And then what happened to those images on the back end, on the computational side, was that we analyzed them, first applying a convolutional neural network to train an algorithm to understand the 10 most common types of brain tumors that we encounter. And ultimately, we implemented this in the operating room and ran a prospective trial in 278 patients and demonstrated that the application of this technology and workflow was essentially comparable to the performance of a set of human neuropathologists, just interpreting the H&E slides that would have come out a couple of days afterwards. And the very cool thing in this prospective trial of 278 patients is that the mistakes that the AI algorithm made were entirely non-overlapping with the human mistakes. And that leads us to the understanding that had we applied this AI as a combination, if we looked at the union of the two algorithms prioritizing what the pathologist was seeing, we essentially would have made 0 errors. And so it really gives us an understanding of the potential of artificial intelligence to be something that is an assistant to a human pathologist. And if we think about a resource low setting where there isn't a neuropathologist at the ready, we have an opportunity to deploy an algorithm that performs at the level of a board-certified neuropathologist. So this was really, I think, an important landmark in our understanding of the way that artificial intelligence could enable brain tumor surgery. A lot of the classification that we were using is the same that's been used for many years, going back to the days of Eisenhardt and Cushing and Bailey, who published in the 1920s about these subtypes of tumors. And that distinction is based on histologic features that we were able to train an algorithm on. So it really says a lot about how far the algorithms have come in being able to pick up the features that we use for making diagnosis. However, when we deployed this, we realized that so much of diagnosis of brain tumors today, and this may be a part of the symposium, relies on molecular diagnosis. And the molecular landscape is actually not terribly complex. There are a couple of alterations, IDH, ATRX, 1P19Q, primarily, that can differentiate amongst all of the most common types of diffuse glioma that we see in our clinical practice. And so we felt like it would be valuable to take some of these stimulated Raman histology images of glioma, and we had accumulated over 1,000 at that point. We're well over 3,000 at this point, and apply some of the genetic embedding. And this is something akin to what large language models are doing now. It's looking at the relation of different genetic alterations to one another and associating those with the imaging features to create a single unified algorithm that incorporates both imaging features and the genetic landscape of human brain tumors to forecast genetic diagnosis in the operating room. We did another prospective trial in 153 patients and demonstrated that our ability to predict molecular diagnosis was, with the algorithm that we termed deep glioma, is comparable to the performance of modern molecular techniques for diagnosis of brain tumors, with the ground truth being sequencing. There are some that we miss, and the ones that we miss, I think, are some of the most interesting cases, but our performance is essentially equivalent to what IHC would be, but is able to be accomplished in the operating room in minutes instead of having the long turnaround time that IHC would require. We can see non-canonical IDH alterations like an IDH2 mutation or R132S mutation, simply because there are no major histologic differences between those, but IHC is not smart enough to pick that out. So we have, in some ways, a better method based on artificial intelligence to detect these IDH mutant gliomas. Why is that important? It's important because we know that patients do the patient's prognosis and course after surgery is different depending on whether patients are astro or oligo. This is an area of controversy. I think some surgeons feel like, well, we might as well just go for maximal safe resection in every patient. But I think a more nuanced way of thinking about this is that knowing that oligodendroglioma patients don't really have curves that separate gross total resection minus versus gross total resection or gross total resection plus, that essentially what that analysis is telling us is that there's not much surgical difference between a very aggressive resection and one that's a little bit more conservative. For patients with oligodendroglioma, maybe we shouldn't be going that extra mile on a tumor like this that looks like it infiltrates the motor cortex. On the other hand, for astrocytoma, we know that there's a very big difference, and these curves separate pretty rapidly within the first couple of, the first 5 to 10 years. We reach the median survival for astrocytoma patients. So for a patient with an astrocytoma, we really think that it's probably better to go for broke, even if we're pushing the envelope of what might cause a temporary neurologic deficit, because the survival benefit is so much better. So this is one way in which we're using that histologic data to inform artificial intelligence algorithms that dictates how we should be operating. That being said, one of the things I wanted to talk about in the last couple of minutes of the talk is the limits of what artificial intelligence can do. And as part of our implementation of deep glioma, we looked at where the algorithm was failing. And we've done more work on that more recently. And basically, the algorithm requires a very clear image of the core of the tumor to be able to predict accurately. Like any algorithm, if you're putting in low quality information in a testing set into the algorithm, you can't expect the algorithm to magically be able to draw the correct conclusion. And we demonstrate that when there's too much blood in the specimen, if there's too much necrosis, if you're at the margin of the specimen, the algorithm doesn't really work very well. And given that one of our missions was to develop an algorithm to help differentiate tumor from normal brain, that's where we started this discussion. We've recently started to apply technology outside of artificial intelligence to close the gap on that. And in particular, we've developed this ultra rapid PCR workflow. We're talking about under 15-minute turnaround time that gives us not just the molecular subtype, IDH mutant or wild type, but also the variant allele fraction in the operating room. And our goal in this project was to accelerate droplet digital PCR to target clonal hotspot alterations to actually quantify tumor cellularity at resection margins. We did this by modifying a number of the steps of the droplet digital PCR process. And what we were able to do is decrease the extraction time, decrease the thermal cycling time from essentially over 2 hours down to under 3 minutes. And we transitioned all of this to the operating room using technology that can fit on a cart. Essentially, we're developing a microfluidic technique, and we just found out that we'll receive NIH funding to enable this project. But the vision is to create infrastructure that doesn't rely on hot water baths and the typical droplet reading technology to allow us to have a microfluidic device in the operating room that gives us this type of data where we can evaluate the cellularity of tumor at the margins of our resection cavity. We get variant allele fraction. We're able to get the cellularity from stimulated Raman histology images, and then actually define how many tumor cells are left at our margins. Interestingly, this is a deeper look at one of those cases where what seems like the core specimen may not actually be the core, and that the margins of our resection cavity actually contain more tumor. Especially in a redo, it can be really challenging to differentiate between core tumor, areas that are densely infiltrated, and areas that are less infiltrated at the margins. And now we have a quantitative way of doing this. We'll report in the coming months on the initial case series of patients in which we've deployed this technology. But we know that there is tumor at the margins even when the MRI is clean. In this case, in this 2021 scientific report paper by Sean Harvey-Jumper and his colleagues, there was residual disease that was observed. These were wild-type gliomas, but there was residual disease that was MRI undetectable in about half of the cases. So, if we're looking back at the ddPCR specimen, we can see that in the tumor core, what we perceive to be the tumor core, there's a wide variability of the tumor cell percentage there. And at the margins, we see a situation where some of our margins contain densely infiltrated tissue, and some of them are sort of intermediate, and in a small minority of them, we actually get it clean. What's cool, though, if we break down individual cases, is that there are some situations when we can resect down to the point where there really is an undetectable degree of tumor cellularity at the margins. And I think that this probably represents some of those anecdotal cases that surgeons love to share, where a patient was operated and didn't seem to recur. And my hope is that, we understand diffuse glioma as a diffuse disease, and we're not under any illusion that we're going to be able to cure patients with surgery that have a very diffuse disease. But in terms of defining where we should be stopping, the level of certainty that we should have at our margins as neurosurgeons, we would love to be in a situation for IDH mutant gliomas where we're getting down to an undetectable level of tumor cells. So that being said, we're running a trial now that we're working very hard to get FDA approval for, that will allow us to use this PCR technology from essentially, it's a bench to bedside trial where we're applying this technology to measure variant allele fraction and then go further. If we detect tumor in a safely resectable area, go ahead and take that out. And we'll follow those patients over time and see if we can bend the curve even more in terms of survival on those patients and be able to predict the patients who might have recurrence. The vision, I would say, for the next 30 years incorporates artificial intelligence for forecasting the genetic alterations. Of course, mapping is going to be very important in ensuring optimal results. But also, we're going to draw on the best of what's coming out of the wet lab technology through droplet digital PCR and bring all these things together. We aim to develop something that allows us to truly deliver the optimal care, surgical care to our brain tumor patients. So just wanted to thank some of my collaborators. All of this work that I present is truly team science, there's so many people who have put effort in. I feel like reflecting back on all of this, I've just been sitting there and like absorbing the greatness of all the people that I've worked with. And I feel a little bit embarrassed presenting all of this as my own work, and just wanted to close by acknowledging that it truly is team science. And I think the path forward is by a collaboration between clinicians and scientists. Thank you.
No, thank you, Dan. That was just a great talk. And Dr. Day and I were sitting in here. We have so many questions, but we'll hold all these until we have our panel discussion at the end. Just for the people that are online panelists, and in addition to our attendees, know that the chat function is active. If you have questions that you would like to ask any of our presenters, once we hit the panel discussion, please do not hesitate to utilize that to write those down. So we'll move on to our next presenter. Dr. Yu Zhang is a leading investigator at UT Southwestern Medical Center, specializing in the application of artificial intelligence to neuro-oncology and advanced imaging. His work focuses on leveraging machine learning to improve tumor characterization, treatment planning, response assessment, particularly through the integration of next-generation imaging platforms. Dr. Zhang's research has helped bridge the gap between computational innovation and clinical decision-making, positioning AI in particular as a practical tool in the care of patients with complex brain tumors. And he's going to give a talk to us today titled "A Diffusion-Weighted MRI AI Agent for Treatment Outcome Monitoring and MRI-Guided Adaptive Radiotherapy." Dr. Zhang, thank you so much for joining us, and we're looking forward to your talk.
Thank you very much for the introduction. Let me share my screen. Okay, share. Right. Sorry. Can you see my screen?
We sure can. It's just not in presenter mode yet.
All right. Okay, let me do that. Right. Okay. Right. Thank you very much for the introduction. Today I'm going to introduce some of our recent work on diffusion-weighted MRI-based AI agent for MR-guided adaptive radiotherapy. So this is my disclosure. So just before my presentation, I just want to have a short introduction to radiation oncology at UT Southwestern. So we are a relatively a large department, I mean, for the radiation oncology wise. And recently we are having a rapid expansion, especially into the area of adaptive radiotherapy. We have these like techniques using like the MR combined with the linear accelerator to acquire like daily MR images to adapt the treatment based on the patient response or anatomical changes. So which are the main topic that I'm going to present today. So we know that the glioblastoma is or GBM or high-grade glioma. The current standard of care is the radiotherapy and plus the chemo. However, the overall survival is still kind of non-ideal, and especially like considering the universal recurrence and around near to the original tumor bed. So there are currently several key challenges in the radiotherapy. The first is the difficulty in identifying the infiltrative tumor extent from like anatomical images. And also for physicians, I mean, how to tell between the pseudo progression versus the actual recurrence and adapt the treatment strategy remains another challenge. And for radiotherapy, we have long been using like a uniform one-fits-all approach. I mean, through like a uniform dose prescription to the whole tumor, which unfortunately ignores like the intra-tumor heterogeneity to better target those like radio-resistant regions. And also for the conventional radiotherapy, I mean, usually it's like a 30 fraction 6-week course. we are using the same treatment plan to treat the tumor, but it actually missed the opportunity to adapt the plan based on the anatomical or functional changes. So, so then the unmet clinical need are how for us to better delineate the tumor. I mean, using in addition to the anatomical imaging like T1, T2 flare, but using functional imaging to better define the infiltrative tumor extent, and also using the heterogeneity information within the tumor to paint the dose and also monitor the response to allow us to do anatomical or functional guided adaptation. So, the recent radiotherapy has seen like a substantial progress in this so-called online adaptive radiotherapy. So conventionally, I mean, you think about radiotherapy, it's like you have the patient, I mean, simulate and then generate a plan, and then the same plan is being used like throughout the treatment course for like 30 fractions, I mean, daily. But now with this like online adaptive radiotherapy, we are able to, for each of the treatment day, we're able to take like a new image, and then based on the new image, we can access like the anatomical response or functional response, and then based on that, we can adapt the treatment or to replan the treatment to make sure we are actually treating what we want to treat. I mean, every day on our patient. So these are enabled by the latest technology, as previously mentioned, the MR-Linac, or we also have this like CT-based Linac. The MR-Linac are better at delineating those like soft tissues. And you can see that if we do not perform this like adaptation, I mean, due to the day-to-day anatomical variations, the delivered dose can, for instance, on a treatment fraction, can go into the normal like lung tissue here. But with this like adaptation, with the plan being reoptimized using the daily anatomy, we can I mean, make the dose fitted well to the target. I mean, to the original match our original intention. So that's the magic of the adaptive radiotherapy. So, and recently there is a push on going from this like anatomical guidance to this functional guidance, as we know that previously mentioned, the anatomical imaging, I mean, they have its deficiencies in accurately mapping the heterogeneity or the extent of the target. But the functional imaging, for instance, like diffusion weighted MRI, it can work better at highlight like the tumor core on the infiltrative regions, and also to, for instance, to show like the within the tumor, there are these like low diffusivity regions, which are shown to correlate with like the progression-free survival. So if we can be able to target those regions that are more radio resistant, then we are able to have like higher dose there to better treat that region and to reduce the chance of a recurrence, to overall improve the outcome of GBM or HGG cases. So, so first, I just give like a short review of the DWI. So what is the DWI? So the diffusion weighted MR is a technique that measures the random or Brownian motion of the water molecules. So the motion of the water molecules actually in the tissues or the tumors, they are differently restricted. So so this kind of different restriction actually creates like a signal difference, allowing us to tell better than the difference between the tumor and the normal tissue, and also be able to differentiate between like the tumor core or surrounding regions, allowing us to do like a spatially variant sub-regional dose mapping or treatment adaptation. So with this like a diffusion weighted MR technique, so the first use that's currently widely used is for this like a tumor contouring. So in addition to like the conventional anatomical like MR or CTs, we can now combine them with this like a diffusion weighted images, and through like fusion, we can better define, I mean, where the target is, and to more precisely treat the tumor. And another potential use is that if we can acquire these like DW images from day to day, I mean from fraction to fraction, we can monitor the progress of the disease for the physician to have like an early response assessment, and then to adjust their treatment strategy, I mean during the radiotherapy course. And especially now with the introduction of the MR-Linac, we can acquire like a diffusion weighted the functional guided MR, I mean daily, I mean during the treatment, in addition to like anatomical imaging. So by combining their information, I mean we can optimize the plan, I mean according to physicians' intent. I mean by, for instance, like the subregional dose pending to this like radio resistant area to better target the tumor, to customize the treatment for each patient. So, however, I mean, even though these DWI they look like promising, I mean, for clinical use, there are actually many challenges. So the first is that the signal to noise ratio of these clinical DWI images are usually very low, especially in the radiotherapy context. So first, naturally the diffusion gradient applied for this DWI to recover the signals, they naturally suppress the underlying image signal or functional contrast, especially for this like high B value DWI images. And another thing is that for the MR-Linac, because we need to integrate the MR into like a linear accelerator, there's a lot of compromise we have to make. So overall, the gradient of the MR-Linac is weaker compared to an MR-Sim, which introduces like higher noise in the image. And also, more importantly, I mean, if we want to combine this imaging and treatment in the same like day session, in the time-wise constraint means that we cannot use this like very advanced acquisition that takes much longer. So we have to generally use like a clinical friendly, for instance, this like a single shot EPI technique, which has like a fast few minutes acquisition, but resulting in substantially elevated like noise levels, as well as in some cases very severe distortions, as shown on the right side here. So these like low quality DWI images unfortunately make this functional mapping or parameterization less reliable, and which also affect our potential use of that for biological or function guided adaptive radiotherapy. So, and another issue with this like application for radiotherapy is usually we do not have the so-called like ground truth or high quality images to train, for instance, the AI model to correct these kind of like low quality or distorted images. So, so the central the problem is how can we train or design an AI model without knowing this ground truth to correct those issues or artifacts in these images to better fit our clinical needs. And another also another issue is that for these I mean, patients in radiotherapy, usually we do not have like a very large database. So it's like maybe like tens of patients or hundreds of patients. That's usually the scale we are talking about. So in this sense, it's better to design like these techniques for patient-specific model training instead of like a larger population or foundation model-based approach. So in this sense, we developed like an AI-driven diffusion-weighted imaging processing pipeline by combining the three components. The one is for the DWI denoising as to correct those like low-quality noisy images, and another to correct those distortion to better position or localize the tumor to guide our radiotherapy delivery, and another is to based on these corrected images to generate more accurate or reliable functional maps to guide our clinical decision making. So for the noise denoising approach, we developed a method we call a band-limited positional encoder. So the key idea is we are going to map like the image or the DWI image itself to a neural network. So our hope is that through the mapping process, we are able to preserve the underlying structural or functional information, but remove this like noise. So basically, the distinction we made is that the image noise are usually typically dominated by those high frequency components. So if you can somewhat constrain the learning at these high frequency signals, we will be able to suppress the noise from the images. So through this, we used called the band-limited approach. So the key idea is that so previously when we were trying to map these images to like a neural network through this implicit neural representation or INR approach, we need to use like this positional encoding to both learn these low and high frequency signals. But if we can just add like a band limitation to these like signals, which we can naturally suppress this learning at this high frequency regions or band to suppress this noise. And another insight we borrow is from this like noise-to-noise framework. So basically, this idea is that if we have like the same thing, we take like multiple photos, for instance, and but both are noisy. If we use a neural network trying to learn from one noisy image to another noisy image, so what happens is that this neural network will generally be much easier or inclined to learn the true underlying structure rather than the noise, because the underlying structure they are much more correlated than compared to the random noise. So this naturally enables us to learn this signal, but suppress the unwanted random noise artifacts. So so this can be similarly applied to this like DWI imaging scheme. So for these like DWI images, we usually acquire like different B values of a different like diffusion gradients strengths. So basically, we can see that if we are talking about these like different p values, they have these underlying like structures or functional maps. They are more strongly correlated. But on top of it, we also have this like noise, which is the more random or weakly correlated. So if we use like a neural network to trying to learn their mapping or relationship, it will be much easier for us to learn the shared structure or functional information, but drop this corresponding noise information. So we use this without knowing the ground truth. We can naturally denoise original like DWI image and get like a more high quality denoised version. So we then designed like a framework to combine the two ideas I just presented. So first, we used this like band-limited positioning encoding scheme to try to suppress the noise from one way, and another is that we are using this multi-channel input from the different B value of DWI images, trying to learn their correlation of the underlying functional maps or structures, but at the same time like suppressing those like less correlated noise among these DWI images. So, so here just shows like a comparison between different encoding strategies, and here shows our like band-limited approach. And you can see that for like a noisy DWI input, our method can suppress the noise, but the best, I mean, preserve the anatomical or functional structures as compared to the other competing methods. And we also evaluate this on like brain images, and in general, our approach can similarly suppress the noise, but generate like images with the highest SNR as compared to the other approaches. And we apply this to like real clinical cases acquired in our MR-Linac. And we can see that for these high p-value images, they are much more noisier as compared to the low p-value images due to the high gradient of the diffusion. And with our approach, we can recover those like details without over smoothing as compared to the other methods. So that also leads to like a better characterization of this underlying functional apparent diffusion coefficient map that enable us to better localize the tumor and see how what is the underlying functional parameters within the tumor. So we addressed somehow the noise issue of the DWI. So the second challenge is the DWI distortion. I mean, as you can see that if we acquire for the same patient, the on the left is like anatomical imaging, and on the right is the DWI imaging. You can see there's some substantial distortion around especially the peripheral region due to the sequence we used for clinical DWI acquisition, the single shot EPI technique. So because there's usually no ground truth, I mean, telling how we can recover this kind of distortion, a very natural or convenient way is to perform a registration between this distorted image to this like less or non-distorted anatomical imaging to align their spatial coordinates together. However, the one major challenge of this registration is they are cross modality. They are acquired under different protocols. So you can see the intensity relationship is different, making the deformable registration challenging due to these intensity variations. So if we look at this into more detail, we can see that for instance, for like the same like tumor region, if we look at this DWI and then the T1 weighted MR image, you can see that the relative relationship between the tumor and the surrounding normal tissue, they are opposite. So if we directly use this intensity to drive this deformable registration or correction process that leads to high uncertainty. Some metrics like the mutual information, I mean, they are more robust to this kind of variation, but it's more like on a global scale rather than like a local scale. So it can correct like overall global mismatch, but this like local fine-scaled mismatch or deformation, they are more difficult to address. So to solve this, we sought help from like a foundation model, which is called like a minimum modality invariant image matching, which is trying to register like images of distinct intensity through like non-matched landmark pairs. So basically, it's trying to find like through two images, find their corresponding anatomical or structural landmarks that's matching with each other, which can serve as a robust supervision signal to help us to perform this registration. So overall, we used this like minimum-based landmark to supervise our registration. So it's as shown as one here. And then we also use this mutual information, as previously mentioned, as a global supervision signal to overall register the two images. And on the other hand, we also use like additional parameterization of this deformation vector field to overall preserve the smoothness of the deformation, which is expected like global property of the DVF, while at the same time achieving like a dimension reduction to allow us to solve this more effectively without trapping at a local optimum. So here just shows the corrected images by different methods. So using our method, we after the correction, we segment like the tumor and the left ventricle out, and then compare with those in the reference anatomical images. And you can see that it generates like the overall best match, showing the effectiveness of this distortion correction. And we also shows that it can perform uniformly well for different p-value images. And the orange curve shows the structures or boundaries extracted from the reference non-distorted and anatomical images. You can see that originally there's like a distortion causing a mismatch, and by using different methods, our method actually generates like the one matching very well after the distortion correction to the anatomical reference. So similarly, like the quantitative results suggest our method can correct for both like the brain or the abdominal cases. So in the end, I mean, after this like correction, the last thing we need to do is to do this like functional mapping. So conventionally, we use this ADC to map the underlying like function parameters of this DWI. But this ADC, they actually mixed the two signals. One is the true water diffusion, and another is the micro perfusion of this blood flowing in tiny vessels. So to solve this, we instead of using ADC, we use like the IVIM, which is the intravoxel incoherent motion mapping. Basically, it's a by exponential mapping to solve both the true diffusion as well as the fraction of the perfusion. So you see that if you try to use like a more complex model on like noisy or few data, generally it will lead to like this yield condition problem. And you can see those fitted images look very much different from the ground truth because we do not have enough stable signal for the feeding. So to address this, we also trying to use this AI to provide like a global, structure-wise supervision to generate like more smooth feeding rather than like the conventional voxel-based feeding. So we tested this on like the breast like digital phantom through a grand challenge, and you can see that overall with this like AI-based approach, we are able to generate like the functional maps. I mean, better matching with the ground truth as compared with some state-of-art conventional methods. And we apply this to our GBM cases, and we acquire like images of different treatment fractions, and then we compute their corresponding like perfusion and diffusion functional maps. So we visually, I mean, inspection shows that the method generates like more, anatomically or functional meaningful maps with substantially reduced noise. And another evaluation is on these like normal tissues. We also correlate this intra-class correlation. So basically, we expect they to change less from fraction to fraction because they are not under active treatment. They are normal tissue. And basically, we use that. We confirm that the AI-based approach can meaningfully preserve the consistency, I mean, for these normal tissues to generate more reliable functional maps for this IVIM feeding. So overall, I mean, we developed like different methods to correct this DWI, and so to make them chain them together to streamline the process, we developed like a web-based application which allow like the user to use these tools to process the DWI and generate the corresponding DWI functional maps. So as shown here, you can see that we use this like web-based tool. We are able to align like daily functional maps as with these like anatomical images and track how the functional parameters are changing day to day, or how the like tumor volumes are changing day to day for the physician to have like assessment what's the response of the treatment to the RT and make corresponding potential updates to the treatment plan. So, but however, the major challenge of this, you can see that it's still a very laborious process that involves a lot of this handling. I mean, on the images, I mean, on the corrections, and also in the end, we also need a clinician to define like a region of interest, and then based on that to make a clinical analysis or interpretation. So for every MR Linac treatment, we do have like a DWI. So if we need a physician to do this for every image, then it's a tremendous amount of data to process, which is generally not feasible. I mean, to fit into the tight clinical time frame. So basically, in the end, we decided to use the power of the large language model to develop agent to help with this automatic processing. And basically, we combine the different modules. I mean, to be called by this large language model to do automatic data conversion, processing, parameter feeding, and visualization. And eventually, we are using this larger model to query a large database of previous publications and clinical notes to make automatic interpretations, which will serve as the reference for the physician to make their final decisions. So for this GBM or high grade glioma case, I mean, you can see that we are combining this image information, I mean, the health records, as well as this previous literatures, and for this LM agent to do this image processing, and eventually have this output to do interpretation, response assessment, and potential suggestions for the physician to take the next steps. So basically, we developed a tool for the physician to use. I mean, they can, for instance, they can input patient info ID, and then ask the LM to do the analysis, and then plot the daily trending curves. I mean, according to the acquired data, and then the LM will be able to automatically extract or analyze the data and present the results for the physician to review. And the physician, I mean, can also ask the LM to make different changes to the, for instance, the plot. I mean, change from absolute to relative scale, for instance, or to inquiry a different region of interest if they are interested in other anatomical regions. So and then with this, we have this data visualization tool being developed to show eventually, I mean, how the things are changing from fraction to fraction for our patients. And then with additionally with this literature database, the agent is going to make a final clinical interpretation, and which will be provided to the physician automatically to make corresponding facilitate corresponding clinical decisions. So here just shows an example. You can see that this is for one specific patient case of with different DWIs acquired at different days and being processed. So overall, this agent will make overall interpretation. What's the changing of these parameters within the PTV or the target, for instance. And then it will have interpretation. What's the biological meaning? I mean, of these functional value changes based on the literature database we provided. And then it will generally have interpretation based on the diffusion features as well as the the perfusion features, and to generally then based on that it will have overall assessment. I mean, whether it's a response, I mean, pseudo progression, or this a tumor progression, and then based on that has the corresponding final interpretation or suggestion to the physician. Of course, the final analysis or decision still, I mean, at the physician's hands when they are looking at these images. So in addition to these CNS cases, we also validate this on cancer sites, for instance, head and neck. I mean, being able to interpret these functional parameter changes and make corresponding clinical recommendations. So in the end, I want to also introduce the last project that we are having, and because now we have these images tracking the daily changes, but what we would like is to have a potential outcome prediction for us to guide a future intervention on these patients. So basically, we are collaborating with Dr. Hermes from the UT Austin to develop digital twin based on the information we extracted from this DWI, and we can incorporate this mechanistic information or physical information like cell density or diffusion, perfusion, or the response to the radiotherapy, and use that to predict what is the cellularity change of for instance, the tumor region. And you can see that we can compare what the predicted, like for instance, cellularity against what's actually measured, I mean, from day to day in our MR-Linac treatment, which shows a very promising correlation. And eventually, we want to use this kind of prediction to help the physician to see, I mean, based on the current regimen, treatment regimen, what will happen, and then use that to fine-tune their treatment dose fractionation scheme or to dose banding scheme to better target those like radio-resistant regions of the tumor. So in conclusion, we shows that the DWI can be very useful, especially nowadays with this adaptive MR-Linac scheme to help us to finding those like functional active or inactive regions to better do dose banding and treat the tumor. And AI can be very useful to process these images automatically and streamline the workflow and provide like useful information for the physician to make decisions. However, there's still rigorous clinical validation needed from the physicians, and how to use these AI tools like safely, effectively, and into the clinical flow still remains to be investigated and optimized. And thank you very much for your attention.
That was just a great talk, Dr. Zhang. Thank you so much. We appreciate you. Again, we'll hold questions until our panel discussion after this first part of the morning session. So, and we will move on to our next speaker.
So it's my pleasure to introduce our next speaker, Dr. Sam Bobholz. Dr. Bobholz is an assistant professor in the Department of Radiology at the Medical College of Wisconsin. He graduated from the University of Wisconsin-Madison with a Bachelor of Science in 2018 and received his PhD in biophysics in 2022. His prior work has included MR imaging-based studies in sports concussion, epilepsy, and schizophrenia, as well as global health research into disparities in epilepsy care in Uganda. Currently, his work focuses on improving the non-invasive detection of brain and prostate cancer using radiopathomic approaches that merge pathology information from human tissue samples with clinical MRI. It's a pleasure to work with him. It's a pleasure to collaborate with him. I can say I'm personally very excited on what he's doing, and look forward to hearing his talk.
Thanks for the introduction. Just to give a brief overview on what I'll be going over today, I'll go over some background, some of the clinical features of glioma, and then talk about kind of our specific use case, which is tumor outside of contrast enhancement, which was kind of the main clinical problem we're targeting with our research. I'll talk about our methods for rad pathet autopsy. This is something we've kind of pioneered and developed over the past 15 years, and we're kind of really excited about our solidified workflow that we've developed. I'll talk a bit about tumor probability maps. This is kind of our main AI application, which is something we've developed for kind of identifying this non-enhancing tumor non-invasively. I'll talk mostly on its development and then kind of give a brief description of some of our applications on external data sets. And then I'll briefly touch at the end on some of our next steps as we kind of enter into the transcriptomics domain. So starting with some background, I don't need to remind everyone here that GBM is a common and lethal disease among CNS tumors. It affects roughly 2.5 people of every 100,000 people worldwide. I think everyone tends to know someone who's experienced glioblastoma. And as we all know, despite advancements in treatment, survival estimates remain dismal. We see about a mean survival of 12 to 18 months still. Some of the pathological features that make glioblastoma, formerly glioblastoma multiforme, difficult to treat are the fact that there is such a heterogeneity in the pathology. So we see traditional hypercellularity. We see things like pseudopalisading necrosis, where that kind of infiltrated front, that hypercellularity is mixing with some of the necrotic features. And we also see features like radiation necrosis, which can kind of appear as tumor on post-treatment imaging. This kind of makes it difficult to identify where the tumor is. So for treatment, we see that a lot of the initial targeted treatments, things like that initial surgery and then the radiotherapy delineation, require precise localization of tumor pathology to maximize efficacy. We want to capture as much of the tumor as possible when we're treating, resecting, and radiating these tumors so that as much of the tumor that is killed off and is able to kind of be treated. In addition to some of these targeted treatments, we have things like Avastin and other anti-angiogenic agents, chemotherapy, and things like Optune, which are a little less targeted and kind of work as kind of symptom management and have shown some benefit, but it's really kind of this surgical and radiation window these kind of localized treatments that are really the front line for GBM. So clinically, how we currently image patients is with MRI. We have our traditional T1 image where the tumor kind of shows up. But luckily, we found that gadolinium agents are able to cause this tumor to enhance by kind of capitulating on the leaky vasculature the tumor develops as it starts to grow. This allows for this nice enhancing region where this angiogenic tumor appearance appears bright after the administration. But again, as we've kind of seen, we've developed the Neuro-Oncology Brain Bank here at MCW. We've collected over 100 brains. Yesterday, we collected our 178th brain, so we're approaching 200 pretty quickly. And what we do with this Neuro-Oncology Brain Bank that's a little different from some of the other kind of Alzheimer's brain banks around the world is we couple this with the imaging close to death and really collect the tissue so that we can make sure that the tissue is collected in line with the MRI as much as possible, so we can look at the relationships between MRI and histology and see, are we actually visualizing the entire tumor on imaging? And essentially what we see is now we see areas of hypercellular tumor well beyond the enhancing region. This is even a flare, hyperintense absent region, far, far outside of the tumor. This is about 12 days between imaging and death as well. So what we're really seeing here is, as much as we use the contrast agent, we all kind of know tumor exists well outside of the boundary. We've looked at this kind of qualitatively in our study of just patients who have large areas of contrast enhancement outside of tumor versus patients who do kind of have those well-circumscribed tumors. And what we see is it occurs in about 2/3 of patients. This is kind of a lower bound because we're not kind of looking across the whole brain, but it gives a good kind of startling estimation as to how frequently this can occur. We see it occurs more commonly in grade 4, which makes sense. These are more infiltrative tumors. And then critically, it occurs more frequently after treatments such like radiation and bevacizumab. So kind of in this post-treated state, this tumor is kind of behaving differently than it did prior. And then critically, we see that patients with tumor outside of contrast tend to show worse survivals here. In our data set, we're seeing a 4-fold decrease in survival. So this kind of non-enhancing tumor, this tumor that's being spared treatment, we think is kind of impacting prognosis. And if we can kind of treat this tumor and visualize the whole tumor using non-invasive imaging, perhaps we can lead to better outcomes and more complete treatment of the tumor. So with our data set, we've kind of hypothesized that radiopathomic models, kind of machine learning models of tumor probability, can accurately identify that tumor outside of traditional imaging signatures using that autopsy tissue data as ground truth. So how do we go about doing that? We go into our methods for ad-pathed autopsy. This is something we've slowly developed over the course of the past 10 years, again, focused really on getting a good MR histology alignment. So this kind of starts with our MRI processing. For this, we've been using clinical time points. This helps a lot kind of with just collecting data near mortality. It's tricky to bring patients in kind of leading up to death, and particularly tricky when they're having advancing GBM treatment. So usually our imaging is within about a month of death. We brought in a couple patients to do kind of advanced research imaging where we've had a couple that we've been able to serially image as they get closer to death, but it's kind of the best we can do. And we're looking to kind of correct this with future machine learning models in the future. So for our processing, we're just kind of aligning everything to the FLAIR image and doing a quantitative or qualitative normalization of some of the images. Pretty standard image processing on the MRI side. For the tissue processing, a little less standardized. So with our tissue processing, we start at the fixation stage. We've seen that when a brain sits in formalin for 2 weeks in a bucket, we see deformations in the areas where the brain kind of makes contact with the bucket. So what we've done is developed 3D printed brain cages. You can see that here. And what those allow us to do is prevent that deformation while it sits in formalin, allows it to fix in line while kind of keeping that architectural similarity to the MRI. In addition to that, once we go down to the actual brain cutting, we use these 3D printed slicing jigs. Both of these are printed per patient using their clinical imaging. So everything is very much per patient. We print one of these slicing jigs, which has the slices in line with the MRI, so we can slice the actual brain in line with the slices of the MRI itself, kind of giving us this good one-to-one alignment per slice. And then we've got these kind of MR resembling brain slices. It's a little different for the pathologists who are used to slicing coronally, but the speed at which we can kind of cut helps kind of balance the trade-off there, as long as we can manage our left-rights as a team. So after that, we take samples from not only areas where we expect there to be tumor, but kind of that infiltrative tumor edge as best as we can find it, as well as kind of areas we don't necessarily expect there to be tumor. So often we'll take like corpus samples in patients where we expect maybe some corpus invasion, even if we don't see it on the imaging, and we've seen it kind of fairly commonly in our cases, more commonly than not. Once we have our tissue samples, then we bring them into digital space. We stain them for H&E. We've also done a bunch of IHC stains. We have things like Ki67, SOX2 for measuring different kind of tissue characteristics. I'll primarily focus on the H&E here. We'll stain our tissue, digitize it with our Huron microscope, which images the pathology slide at 40x. These are really, really big images. Each one's about 20 gigabytes. We get like 3 to 20 per patient, so this data set kind of explodes in size very, very quickly. But what this digital pathology allows us to do is then to computationally segment where the cells are, where the cytoplasm is, and where the extracellular fluid is, and use that as a ground truth for developing our models. We're also able to annotate the data. So we had a pathologist trained technician annotate for areas of infiltrative tumor, pseudopalisating necrosis, which again is considered tumor, and then also the non-pseudopalisating necrosis, things like radiation necrosis, in addition to kind of the normal tissue. And then once we have kind of our pathological information and our imaging all processed, we can bring the two together using our in-house software. What this has done is it allows us to use nonlinear warping from manually defined control points. So we'll have someone individually kind of place these points on areas of architectural similarity using kind of the gyral structure and also the tumor itself to define a nonlinear warping that allows for correction of some of the nonlinear shrinkage of the tissue during fixation and lets us get this one-to-one comparison between voxel and the underlying pathology at autopsy. We also define these regions of interest based on the quality of the MR and the histology, so we're avoiding things like rips and tears, as well as artifacts from the imaging, things like motion. So once we've got these two data sets merged together, we're able to start developing AI models that communicate between the two. So for this, we've developed what we call tumor probability maps and radiopathomic maps. Get into that now. So for our initial model, what we wanted to do is to kind of understand which pathological features kind of predict that tumor presence. So we did a kind of initial study of 6 training subjects, 3 test subjects. It doesn't sound like a lot of data, but when you look at the actual number of voxels being incorporated into this, it's about 300,000 voxels. So our actual N for training this model is fairly sophisticated, even if we don't have the greatest subject representation. And all we were kind of looking to do with this model is from our pathological segmentations, can we predict tumor versus no tumor? Doesn't seem too hard. And in fact, it wasn't. We were able to use RUS boosted tree model, which is a fairly kind of standard traditional machine learning model, not quite deep or anything like that. But what it does, it allows to count for imbalanced data. We have a lot more non-tumor than tumor. And we were able to generate a model that with an accuracy of about 0.86 is able to predict the location of tumor on pathology samples. And we see it again here, it's reliably kind of tracking the spatial distribution of these kind of orange and blue regions. These regions we consider either infiltrative or pseudopalisating tumor. Trickier part is kind of developing the MR to histology communication model. So for this, we used a larger data set of 43 patients and a test set of 22 patients. And we looked to predict voxel-wise cellularity, extracellular fluid, and cytoplasm concentrations just using the MRI. So for this, we used 5x5 tiles from the T1 plus contrast, the FLAIR, and the ADC images. These are commonly acquired for every patient. This allows us to apply our models to really kind of any brain cancer patient. Since we've developed the models, we've applied them on scans as old as 1980 and gotten reliable predictions. So it's a kind of nice system, even though we don't have things like perfusion or spectroscopy that could improve performance. For this, we then used a bagging random forest, again, kind of simpler machine learning model. For some reason, it seems to handle these tiles better than some of the deeper stuff. And what that allows us to do then is create models that predict kind of the center voxel cellularity, extracellular fluid, and cytoplasm density just using the MRI. It's kind of a complicated process, but what we've been able to do is show that we can predict the ground truth cell density, extracellular fluid, cytoplasm within a standard deviation of its ground truth. So that's pretty good quantitative accuracy. But the quantitative accuracy itself is kind of useless if we're not showing that we're predicting something new. So if we're just kind of highlighting the contrast enhancing region with our model and the errors in the non-enhancing region, we're not really capturing a new relationship. So what we critically wanted to look at is if we are seeing that non-enhancing tumor because we have that pathological data from non-enhancing areas. And what we see is we do see predicted hypercellularity beyond contrast enhancement that matches what you see in the tissue. We also see that it differentiates between the hypercellular and necrotic portions of the flare hyperintensity. Here you can see here the flare extends up here. Our model says the tumor is actually going this way. And again, in another case, we see prediction of hypercellularity in the absence of contrast enhancement, flare hyperintensity, and diffusion restriction that we do see on the tissue. So it seems like we are actually capturing those new relationships in the non-enhancing region that we were trying to identify. So then by merging our two models, that pathology space model and our kind of cellularity ECF cytoplasm models, we can then get what we call a tumor probability map. And what this lets us do is get the probability at which any voxel contains infiltrated glioblastoma tumor. Our model works again with this very conventional imaging, and it runs in about 10 to 15 minutes. And what it allows us to do is, in the absence of contrast enhancement in this kind of areas of uniform flare hyperintensity where it's ambiguous as to whether or not there's tumor there, and we see the subtly increased diffusion on the ADC, our model is able to identify increased hypercellularity throughout the entire tumor region. We see an increased ECF signal for the pseudopalisading necrosis region, indicating that we're kind of picking up on that mix of cellularity and necrosis, and the entire region is correctly identified as high tumor probability. So our maps, at least on our data, have shown fairly good results for what we're trying to identify, which is, can we see this non-enhancing tumor non-invasively? So since we've developed these models, again, they have this kind of very simple input structure. We've then looked to apply our model to a bunch of different publicly available and external data sets to see what we can learn about tumors using this kind of non-enhancing measurement. One of the first studies we did was the multi-site retrospective analysis of diffusion-perfusion magnetic resonance imaging correlates. So this was kind of comparing our imaging, or our new features, to traditional features of perfusion and diffusion. Things we didn't include in our model, but are other common imaging features in GBM to see if we have complementary information, if we're kind of offering the same information. And what we saw in this study, particularly with perfusion imaging, is that within enhancement, we see a really good association between our cell density measurements and perfusion values, RCBV. But outside of enhancement, we see basically no relationship at all. And what we kind of saw at the individual subject level is that it typically showed in this situation where within enhancement, there's pretty good association between the RCBV and cellularity. Once you get outside of enhancement, we see our model tends to identify things that the RCBV misses. So it's kind of missing those parts of the tumor that haven't quite developed the vasculature to show up on enhancement, which kind of makes sense. And we've seen a lot of kind of studies restrict to the enhancing region when looking at perfusion for that reason. Another study we've looked at to look at some of our kind of treatment response characteristics, we developed a system we called phenotypes of studying kind of the non-enhancing tumor front, we called it. So looking at if the non-enhancing area was predominantly hypercellular, hypocellular, or it had components of both, and looking to see if we saw survival differences, and particularly if we could identify a certain group of patients that selectively responded to anti-angiogenic treatment. And what we essentially saw is that phenotypes with a hypocellular presence, either the hybrid or the hypercellular component, showed a significant survival benefit from bevacizumab, where the patients with kind of either well-circumscribed or purely hypercellular tumors showed no significant survival benefit. So this could be kind of used as a screening tool kind of in the later stages of disease to see if anti-angiogenic therapy would be applicable in a patient versus not. And then what we also saw is that you could track the decrease in that kind of hypercellular volume over the course of treatment using our maps. So you see this big kind of hypercellular region at the start of treatment that vanishes at the end of treatment. Physiologically, what's going on here, it's a little ambiguous. We're not able to kind of collect tissue during this to kind of see what's going on under the hood, but some of our later on studies looking kind of more at molecular features, hopefully we'll be able to kind of discern this a little bit more high resolution. We've done a recent study of ours looking at post-treatment GBMs following kind of that initial surgery and radiation. The UCSD PT GBM dataset has recurrence information. One of the big questions when treating a patient after that initial battery of treatment is whether or not a patient's imaging is suggesting true recurrence or pseudo-progression, where it's just kind of an increase in treatment-related imaging findings as opposed to true imaging findings. So this is 243 time points across 178 patients, with 192 of those time points having residual tumor and 51 showing no residual tumor or just post-treatment changes. And what we did is we compared our models to, again, perfusion and diffusion characteristics that didn't go into our models to see kind of how well our maps can discern whether or not a patient is showing true progression or pseudoprogression. And when we looked kind of just statistically, is there a difference in the feature? We saw, shockingly, only the RPM cell estimate and the RSI from diffusion imaging showed significant differences between progression statuses. So we didn't see a difference in CBF or CBD. CBD was a bit closer, but it was kind of interesting to see kind of these traditional imaging signatures for pseudoprogression not performing quite as well in this publicly available data set. And indeed, when we look at the actual ROC analysis, our model tends to significantly outperform the other models with an AUC of 0.827 compared to the next highest, the RSI cell of 0.668, and the highest perfusion feature being at about 0.627. This shows that, again, this is kind of one data set, warrants external validation, but it shows that our maps are kind of capturing these relationships that aren't available necessarily on the other imaging and can offer kind of complementary information for particularly this post-treated state. In addition to kind of the studies we've been able to do at our institution, we have some collaborators at UCLA who have really kind of done some amazing things with these models. They've applied their maps or our maps to their data to look at cellular growth kinetics, so calculating the entire cellular burden of the tumor. And what they've seen is it predicts survival not only prior to treatment, but kind of throughout the treatment process. In addition to that, they've also done an independent histological validation of our maps in the pre-treatment and post-treatment state, showing pretty good association even on their data, where biopsies are showing kind of what our maps are showing, particularly in the pre-treatment state in their data. And again, this is kind of a smaller study. We'd like to get this in more subjects to better understand what's going on. But to see kind of external validation at this stage in a 65 patient model, I think is really promising, especially given what we've seen across the other data sets. So in addition to that, we've kind of looked at what actually integrating our maps into the clinical workflow has looked like, and this is kind of a big thing going forward. We have a collaborative grant with UCSF where we're really trying to build out a system for integrating these in surgical softwares and radiation oncology softwares so that these maps can actually be used and kind of getting clinicians comfortable with looking at them for visualizing for treatment. One way we've kind of done this so far is looking at 5-ALA guidance. It's a fluorescence staining that allows surgeons to go after more of that non-enhancing portion of the tumor. But because it's kind of this 2D solution for this 3D problem, it might not be able to visualize the entire non-enhancing portion of the tumor, just what's available kind of at that surface level. So we looked at how our maps might relate to the 5-ALA boundaries, hoping that we would see really good alignment where that kind of extra marginal boundary aligns really well with what our maps see. What we actually saw was something a little bit different. So this is a case here where we've got this enhancing region prior to surgery. Our map doesn't really highlight much of it. Our map highlights these two spots up here. We see surgeon takes out a bigger whack kind of than what was available, but the patient recurred in these two spots almost exactly about a month later, indicating that maybe seeing these maps on the pre-surgical imaging could indicate going kind of more aggressively for those regions. Again, in this case here, we see the enhancement. We see our maps kind of identify this big area outside of enhancement that's really not highlighted on the imaging. Bigger whack on the enhancement. Recurrence right where we kind of predicted it a month later. So these maps are kind of really timed for clinical use. Again, we've done a lot of validation studies to try and get it to where it needs to be to build confidence. I think there's still more to go. But I think everything we've seen so far has been really promising for showing how these maps can kind of integrate into treatment direction and also just clinical monitoring in the post-treatment state. So some of our next steps as we go forward, we're looking to kind of get into transcriptomics. As much as we have things like cellularity, one of our big questions, particularly pathologically, is what is a tumor cell? And how can we kind of identify a tumor cell so that we have a good ground truth going in? We kind of view transcriptomics as the best way to do this. We've looked at different IHC stains to try and identify one that really selectively identifies it. We've kind of failed to identify a really, really reliable, this is certainly a tumor cell. And even our pathologists kind of have some misgivings about specifically calling a region certainly tumor. So I think using these kind of more metabolic features that identify kind of what's going on at the chemical level, we'll be able to get a better sense of kind of where that actual tumor is. For this, we've been doing or kind of the novelty we bring to this field is we have this large sample size of about 175 brains, which we have banked and we're able to kind of collect from. We've seen a bit of RNA degradation in some of our older samples, but we've been able to run this on FFPE tissue and get reliable results. And a lot of the prior studies occur prior to treatment and not in relation to some of the imaging signatures. With the way we're trying to collect the data, we're trying to preserve that imaging relationship as one-to-one so we can do radiopathomic maps of what we see transcriptomically. One of the kind of ways we've been doing this, we call these porcupine brain cages or pseudobiopsy brain cages, where we're able to develop this kind of tube structure to add on to our brain cages that allows us to take what we, for one of our aims, our kind of bulk RNA sequencing aims. We can take this on fresh samples prior to the actual fixation process and get fresh tissue without disrupting this tissue architecture. And what we can do with that is then do kind of our single nuclei multi-omic profiling, where we have a combination of kind of traditional multi-omics with bulk RNA sequencing to get rapid kind of high subject number data on what's going on transcriptomically in the contrast enhancing and non-enhancing region and what differentiates those kind of tumor compartments. In addition to that, we're also looking at spatial transcriptomics to kind of couple with the bulk. So what we can do then is look at kind of specific subjects and look at that margin of enhancing to non-enhancing tumor as it extends into the infiltrated portion, to look at what features kind of create that gradient and how can we measure the features of that gradient itself. So then with that, I'd like to acknowledge this entire team. It's a really complicated process that's taken over 15 years to develop, and I think we've gotten it to a pretty good point now, but even as we've kind of developed into our transcriptomics stuff, we're constantly looking for new stuff and crazy ideas to try with our data. So feel free to reach out if you have an idea and want to collaborate. And with that, I'll thank you for your attention. Thanks so much.
It's a really great talk, Sam. You know, having had a chance to visit that lab, it's really incredible what you guys are doing. And, you know, for somebody who treats glioblastoma, both of us, actually, Dr. Day and I were talking about this, it's a little terrifying actually to see some of your data with regard to the clinically non-apparent regions of disease that are likely present very early on in the diagnosis that we just don't have the ability to see. So thank you so much for showing that work. I think it's great. We're at the point of our first morning break and question and answer. I do have one question kind of for our, and if we can have all the panelists that had spoken this morning already put themselves back on camera just for the Q&A portion, if that's possible. I have a broad question for everybody that's presented, and even for the presenters that haven't presented yet, I'm curious about their thoughts as well. You know, as AI obviously becomes more embedded in clinical decision-making, how should we think about accountability when AI makes a mistake? You know, who ultimately owns that error, and how do we ensure transparency and maintain patient trust when, you know, the computer made a mistake, not necessarily the human that was using that tool? So I know that's a broad, it's probably somewhat philosophical question, but, you know, as these tools become more frequently used day to day, how do you guys wrap your brains around that as people that are developing this technology?
I think, at least in my end, I'm obviously not a clinician, so it's a little kind of ambiguous for me. I kind of think of it as kind of the responsibility of the model itself to kind of address its own uncertainty and kind of identify its reliability as a feature. We, again, kind of as we've gone over our maps, we tend to think of them as just other contrasts. So if we see something that just doesn't really make sense, so we see like a big hypercellular component nowhere near where we expect the tumor to be, we do kind of take that with a grain of salt as something that could be kind of an imaging feature or something where the imaging could just be a little bit distorted. I think we tend to think of our AI, at least, as another acquisition, another piece of the puzzle, and I don't think it's doing any of the decision making itself. I think it's kind of, at least how we parameterize our stuff, it should be an assist of the decision making and not the decision making itself.
Yeah, so for radiotherapy, I mean, we do a lot of like the quality assurance. So to make sure like the treatment plan, I mean, is according to the standard. I think for AI, we should do the same thing. We should have like a library of cases that's being routinely applied to that like model to make sure, I mean, there's no deviation from the expected results. So, and of course, we need to pay close attention to the data we are acquiring. If we have like a new machine like being used in the clinic, we have to test that the data is not out of distribution, which will distort our AI results. And eventually, I think the physician is the final stakeholder in using this AI. So AI can only make like an interpretation or suggestion, but eventually the physician needs to make the final decision. Yeah.
I have a question for Dr. Poon. I think you touched on it. It's about health equity. You know, if you are training all your model on data coming from big academic centers and these big places, however, 80% of the cancer patients are being treated in community. And if that data is not part of these training model, then are these training models really showing real life, or are we looking at a very small population and ignoring the bigger population?
Yeah, sure. That's a great question. So I want to first mention that there are actually two different regimes. One is like how do we apply sort of like some of those existing frontier AI capability. So for example, in structuring all the information in the clinical notes, right? So those are actually already getting very good, regardless of the source of the sort of the kind of institution and so forth. Certainly there will be room for growth and so forth, and there could be potential adaptation too, but they actually get already very good. I guess your main concern would be, and also in those regime, I would say that for example, in the clinical trial matching case, and like this is actually will be able to help sort of unlock all those kind of like under-resourced kind of patient, right? So because now they become visible for a clinical trial and affordable kind of like cost and time. And there are sort of what you are probably also concerned about is actually in the training regime. Like for example, in training some of those like digital pathologies, like some of those curiosity models and so forth. I would say actually in both cases, they actually our partners are actually the data are pretty diverse. For example, Providence, they have 51 hospital, but they also have 1,000 those small clinics, right? So they are kind of like have a lot of those exactly those kind of microcosm of those community center and rural hospital, and then Epic Cosmos is actually trying to pretty much capture like a majority of the U.S. population. So I would say certainly AI is no magic. So exactly like I said, like we definitely have to be aware of sort of like the potential bias of the source data.
That's great. Thank you so much. Oh, and Sam, I was just going to read that question for you from the chat. That's okay. I appreciate your response, but maybe you want to, just for the benefit of the rest of the group who doesn't have the chat panel pulled up, there was a question from Jack Sharman for you, Sam, wondering if you could talk about the quality of the sequencing data from the interval from death to RNA processing.
Mm-hmm. So it's not something we've looked at too kind of exactly. We've been kind of just trying to find the sweet spot by trial and error. Our first initial studies, we looked at kind of our historical data just because that was the lowest stake tissue. It's tissue we've already looked at in our analysis. We saw it was hard to use. Things we've used kind of in the past year have been more up to RNA quality in terms of like actual, just like DV200 values. We're trying to kind of focus mostly prospectively going forward. We've seen our fresh tissue, at least for bulk RNA-seq, has been kind of the best quality that we've seen, but we are getting pretty good results at that 2-week formalin fixation period for the Visium HD stuff. They have a nice FFPE protocol that allows us to kind of extract what we need from it. Honestly, the biggest issue we've seen so far is just getting enough cells for the actual analysis itself. particularly with the bulk. For that, we've kind of had to take replicates from each ROI. So kind of in those like noodly biopsy brain cages, we'll take 4 needle points usually per tube. That'll allow us to kind of get the cellular content we need to actually measure. But we do see sufficient RNA quality, at least according to our experts.
That's great. Thank you for that answer. Dr. Zhang, I've got a question for you. Just having come from an institution with an MRI linear accelerator and understanding the benefits of acquiring that real-time imaging. And, I know that Zavi Wardak down at your institution utilizes that as well. I'm just curious, with the real-time, if you could comment on how, based upon AI tools, are beginning to inform real-time response assessment during MRI-guided radiotherapy. How do you envision, or how do your physicians envision integrating these signals into clinical decision-making when we're getting these images during the course of treatment that we've never had an opportunity to see before? And how do we wrap our brains around making changes to patients' treatment plans in the midst of radiotherapy based upon this advanced imaging that's performed during patients' treatments?
Thank you for the question. Yeah, that's I guess that's a very challenging. I mean, especially considering this like functional imaging. I mean, the reliability, the repeatability, right? And especially like if we are talking about voxel wise like mapping, how do you trust like the per voxel results and then put it into like the clinical dose painting? That's still requires a lot of investigation. So currently for radiotherapy, I mean, we do see a lot of people are gradually using this adaptive regimen to treat. And for instance, at UT Southwestern, we now have the treatment called PAUSA. So basically, we do not treat like patients as frequently as before, like every day. We now treat them like every 3 weeks or every month. And then between those like radiotherapy pauses, we do like immunotherapy or chemotherapy, and then that will actually work in synergy with the radiotherapy to kind of like shrink the tumor or change the change the tumor. And then you do see like a very substantial changes, I mean, from fraction to fraction because of the long duration as well as the additional treatment coming into play. And at this stage, you do see that there's actually the radiotherapy plays a very or adaptive radiotherapy plays a very large role because the targets are actually very, very different. So but this is still like mostly based on the anatomical imaging. For the functional imaging, I think we are still we collected a lot of data. We collect like hundreds of like thousands of images. So we are currently processing them. And so basically, I think the first step is to, as mentioned, use AI to make sure these images are of high quality, and then to correlate those like functional maps, I mean, through like digital twins or other techniques with the actual clinical outcomes. And once we have like a somewhat like reliable clinical tool to correlate these images with outcome, then we can talk about maybe starting from like a regional based, a relatively large regional based like a painting or boosting to like eventually to like a pixel wise painting. But that will remains, I think, in the somewhat distant future. Yeah.
I have one more question for Dr. Preem. Now, you are working with some of the biggest data sets coming up with all these models. For some diseases, like we're all here for neuro-oncology, we all collectively treat brain tumors that are not that common, thankfully, but it kind of limits us as to how much data do we actually have to train models and do meaningful predictions. So can you speak on that? Like, are there like ways to boost when the data is not that abundant, or how much data do these models need to be trained on to predict things?
Oh, you're muted.
Sorry. Yeah, so yeah, I get asked that question a lot, like how many is enough, right? So on one hand, the answer is like we are nowhere near that diminishing return regime. Even when we looking at the population scale like Curiosity, I would say when we look at the scaling law. So one of the tool that we can look at how much kind of like delta incremental potential return on increasing the data size is to do this kind of scaling law study, right? So they are basically sort of empirical study, usually based on certain objective like predicting next token, predicting next event, that actually as a proxy to like how much the model actually capture the information in the distribution. So and what you often see is there is a kind of power law that you can observe is like sort of like when you boost the scale, you can also substantially reduce the prediction error, right? So in the Curiosity, even though that's a kind of like hundreds of millions of structured patient journey, we actually still see that there is sort of like in our current training in terms of sort of like the computation we can afford in the previous training, it's still nowhere near diminishing return. So even at that scale, I would say there are sort of like more data, more compute, definitely helpful. I think, but in reality, as I sort of like looking into, also there are the regime where you often don't have that many data points, right? So for example, for the kind of spatial, that's actually motivating our gigatime work in the cell paper, is like exactly in the regime where actually there are many of this kind of high value kind of regime, but you just cannot actually have that many data points at this point. So there are several ways that I discussed a bunch of those. I joke about that they are free lunch, right? So basically there are one principal way is to try to reduce the dimensionality, because that's actually if your dimensionality is much smaller, when you have much better feature representation, even a few data point can actually give you some pretty good learning, right? So if the data, for example, truly is a linear relationship, then even like 3 or 4 data point can find that, linear, right? So, but the question is how do you get to that reduced dimensionality? So this is sort of like some of those self-supervision pre-training can helpful, because they basically look at like lots of like, for example, lots of MRI, you can train an MRI foundation model, lots of CT, you can train a CT foundation model, even though they may not be purely the brain, the precise condition, but they are still roughly kind of like that kind of modality, that kind of a lot of the underlying structure, so that will still be very helpful. And then another potential way is that if you can actually find some really precious kind of like Rosetta Stone that link up to modality that are related, right? So then you can potentially using a much more affordable modality to do the one. So for example, I particularly find the last talk very exciting, like sort of like you correlate, red path correlate. So radiology, non-invasive, much easier to get. Pathology much harder to get, right? So if we can learn a really good correlation between them, that would be very helpful. So those are probably at least a couple of the directions. Yeah.
Thank you. That was great.
Yeah, fantastic. Well, what a fantastic kickoff to our morning here. Oh, was there one more? Yeah.
Max.
Yeah, Max, do you have a question?
Oh yeah, if we've got time.
Yeah, we do. Yeah, absolutely.
Yeah, brief question for Dr. Zhang, and then a brief question for Dr. Bob Holtz. So, Dr. Zhang, we've heard a lot this morning about how diffuse gliomas are, and the sort of discovering them way outside the margins of enhancement. And I've also just kind of generally noticed a trend towards trying to apply proton therapy in gliomas. And I just wonder if you have a general sense or philosophy on whether how sort of proton therapy either fits or doesn't fit in the treatment of diffuse gliomas. And then my question for Dr. Bob Holtz is, are you guys finding anything beyond flare? Like, I know you're talking a lot about beyond contrast enhancement, but I'm curious to know if anything's turning up positive beyond flare signals.
Thank you for the question. Yeah, I think proton definitely is like a hot field now in radiotherapy. I mean, overall, the proton works better at precisely targeting the tumor, but spare those surrounding normal tissues. So I guess it depends on the case. So if the GBM is very close to like a OAR or like the optical nerve or something, then proton definitely can be more, normal tissue protective than photon. But overall, I mean, if that's in like the inside the middle of the brain or something, then usually there's not that substantial advantage compare, proton over photon. And we do also see there's also a progress in photon field as well. I mean, due to this more better optimization and better sparing. So usually nowadays the photon can in many cases achieve similar like dose sparing as compared to proton. So on the I think more in like the cost benefit like equation wise, there's it's hard to say like proton is definitely better, especially for like a GBM. And it's more like a case by case scenario. Yeah.
Yeah, thank you. I wonder about if we're accidentally under-treating with proton therapy. That's sort of my question, is if you get these sharp margins on your treatment, then you're
Right.
sort of under-treating the areas around it. And I think Sam showed a slide where he could differentiate, if there was tumor outside the treatment zone, those people did a lot worse. And that's sort of my concern with applying protons for sort of a diffuse disease. And I wonder if that's a concern that's shared or not.
Right.
Not needed.
Yeah, I think. Yeah, I think that's a very critical question. I mean, regarding how do we define the tumor, right? If you can define the tumor with this like infiltrative region, then that's no problem. They're equivalent. But usually there's a large discrepancy there. So just for our practice, for instance, because for this adaptive therapy, every day, I mean, the treatment, the physician may not be follow up on the same patient from fraction to fraction. So there can be different MDs, covering the same patient. You do actually see, physician-wise, they also have very different contour from day to day. So how do you, because I think one of the issues is for this anatomical imaging, they do not have this good power in finding these infiltrative regions. So I think if we can have some improvement on the imaging wise to quantitatively or accurately define this true tumor extent, then basically we will be able to treat this better. Either proton or photon. Yeah, but in this sense, if we do not know exactly the tumor extent, maybe for, I cannot say for 100%, but maybe photon can actually have some benefit because it can have maybe has less sharp like those fall off, so it can actually cover this extent a little bit better. Yeah, but it's all like conjecture. It's not like scientifically proved yet. Yeah.
Thank you. That makes a lot of sense.
And then regarding tumor outside of FLAIR, we've seen it maybe, I'm going to call it 5% of cases. We definitely see it. It's a lot more rare than our tumor outside of contrast. We actually had a case last week that we did at the brain cutting on where we saw a substantial tumor outside of FLAIR, like kind of what we see outside of contrast, outside of the FLAIR. And I'm really curious to get those results back because we got some really good Visium HD samples for that one. So I'm excited about that a lot. In addition to that, we have recently done a study. I don't remember what the current results are in terms of covariates and what I actually shaked out, where we looked at a strip 10 millimeters outside of FLAIR. And I think we saw a prognostic signal, but it's still something I think that is a little underexplored in our area. And it doesn't happen frequently enough where we've been able to kind of do a formal study of it.
This is a question from the chat, and I promise we'll get everybody their bio and coffee break after this. Regular attendee of our conference and a fourth-year medical student from Pakistan, actually, we're international. I've been listening to all these advancements and they're wonderful, but how can we translate these to LMICs where there are no resources, funding, and the patient undergoes redo craniotomy again and again without the neurosurgeon knowing what they're actually resecting? So I think the question is asking the group, how do we broadly apply these amazingly sophisticated technologies to the community, and where is their equity in that?
I can speak a little bit on this, less so on our brain side. Our brain stuff is kind of mostly focused on traditional MRI. We've kind of kept it away from things like spectroscopy in an effort to kind of approach equitability. It really is kind of dependent on MRI though. We have similar work in prostate cancer where we're looking to develop kind of an MR-based prostate cancer screening using a similar technique where we're doing radiopathomics of prostate cancer biology. And one thing we've looked at doing as we've kind of moved towards a screening that is equitable and at least available to more people here, as opposed to people who can afford to get that hour MRI, is kind of hemorrhage our data a little bit or distort our data a little bit to look more like what you would get on like a portable hyperfine system, so that you can kind of bring a portable system to get patients in for like a 5-10 minute scan as quick as possible. And allow for that kind of screening to occur as kind of cheaply and as effectively as possible in as many settings as possible. So I think kind of looking at ways you can kind of reduce the quality of the input of your model to even kind of simulate what you would see with kind of higher quality information might be the best way to go. And I think AI is kind of weirdly attuned to do that well.
That's fair, Sam. All right. This was an amazing morning. Thank you to all of our panelists for kicking off a great conference. We'll give everybody about 10 minutes. We'll start at 10:35, and we'll see everyone back after the morning session. And we have an even more exciting afternoon or later morning session. So please make sure to log back in. Thanks so much. Okay, welcome back, everybody, to the 6th Annual Primary Central Nervous System Conference, hosted by UW-Madison, Frederick Medical College of Wisconsin, and DataCare. Thank you for those of you on the call who have stuck around for our super exciting second part of our morning. And I'll turn the floor over to Dr. Morris.
Great. Thanks, everyone, and welcome back. It's my distinct pleasure to introduce Dr. Nadine Huzri. She's a radiation oncologist and associate professor of therapeutic radiology at Yale School of Medicine. Her work is distinguished by a focus on translating complex clinical evidence into practical, real-world decision-making frameworks. As co-founder and chief medical officer of the MedNet, she has built one of the leading physician-driven knowledge-sharing platforms designed to bridge the gap between expert insight and everyday clinical practice, enabling oncologists to access high-quality, experience-informed guidance across the globe. Dr. Huzri's leadership at the intersection of oncology, digital health, and clinical knowledge dissemination has been recognized nationally and for advancing new models of care delivery and physician collaboration. Her work increasingly centers on how artificial intelligence can augment, not replace, clinical judgment, emphasizing systems that incorporate real-world nuance, expert reasoning, and workflow integration. She brings a uniquely practical perspective on building out these AI tools that move beyond evidence synthesis towards supporting high-stakes, individualized oncology decisions in the exam room. We look forward to hearing her talk.
All right, thank you so much, Brett. That was probably one of the best introductions I've ever gotten. So I will share my screen and we'll jump right into it. So the title is From Evidence to Judgment, Building AI for Real-World Oncology Decisions. So when Brett reached out to me about the symposium, I was actually reflecting on a talk that I gave 3.5 years ago at the ASTRO annual meeting, presidential symposium. And at that time, when Brett reached out, I was actually writing an article reflecting on this meeting and sort of the predictions that I had made in this presentation and where we are today, 3.5 years later. So I made 3 predictions about how AI would reshape knowledge sharing in medicine. And 1 month later, OpenAI launched ChatGPT. And so I think it's worth, sort of digging into what's happened in medical knowledge sharing over the past 3.5 years and whether we can be optimistic about the future. And I think we can. So The first prediction, so the first prediction was that AI systems would guide knowledge sharing where knowledge is known. The second, it was that for unknown knowledge, AI would bring the collective wisdom of physicians to the point of care. And the last one was that a physician's role would shift from an acquirer of information to an interpreter and a caregiver. So we'll dig into prediction number one. Today in 2026, that first prediction that AI would guide decision-making where knowledge is known, it's painfully obvious. Within 1 to 2 years of the emergence of LLMs, we went through from a world where we did manual literature searching, time-intensive evidence review, and there was these fragmented information sources that we had to comb through, to a world where we now have rapid evidence summarization, easier information access, and consolidated source review. Today, over 80% of physicians use AI in clinical practice, up from 38% in 2023 and 66% back in 2024. And the AMA has actually been doing these surveys for the past 4 years. What year are we at? The past 3 years. And has reported this as one of the fastest technology adoption curves in the history of medicine. The number of clinical AI tools that guide decision-making where knowledge is known, and not only do it, but do it exceptionally well, they grow every day. From AI specifically built for physicians like Open Evidence and DocsGPT, to general AI chatbots like ChatGPT and Claude. This idea of evidence retrieval, guideline servicing, and point-of-care search, they're no longer a thing of the future. I mentioned a few players here on the slide. Again, it doesn't seem that long ago where we didn't have any. In 2023, Open Evidence and DocsGPT launched. In 2025, UpToDate Expert AI. And in 2026, and it's only April, Medna AI and ChatGPT for clinicians, which launched 2 days ago. The way these differ from general purpose, well, first of all, how do generative AI clinical tools work? So a physician types in a clinical question in a natural language, and then the LLM generates a narrative answer, often with citations to published literature. So the way that these work from general, or how they differ from general purpose LLMs, is that in those LLMs, they're basically generating answer based on patterns it learned during training. So if you go to ChatGPT, it's sort of predicting the next word that it's going to generate based on patterns it learned during training. These systems often include retrieval augmented generation, or a RAG system, to pull from curated sources like PubMed or guidelines. And then some layer on this like agentic or structured workflow that allows for step-by-step reasoning. So like an agentic system would extract patient details and then retrieve the guidelines, then check for possible conditions, then check contraindications, then compare treatment options, and then generate the recommendation. So it's a step-by-step reasoning. There's obvious limitations in how good these systems are at answering oncology questions. In all honesty, I'm hesitant to even discuss how good the systems are because the data is outdated as soon as it's published. But needless to say, the systems perform very well when it comes to structured board exam questions, not as well when you start introducing actual clinical scenarios. Some of the practical limitations is that the answers are only good as the data that the model uses. The interaction is one physician, one AI. There's really no connection to what other physicians think, do, or have encountered. The data revolves rapidly, especially in oncology, and clinicians often have questions on how to apply new data into practice. And that AIs operate in a black box. There's really low reasoning transparency. And then, very obvious to those of us who treat cancer patients, the hardest questions in oncology, they aren't really answered by published literature. There's been a number of studies that looked at NCCN guidelines specifically, and only 5 to 7% of recommendations are supported by Category 1 evidence. Most recommendations are lower level evidence with expert consensus. So even guidelines are mostly expert consensus driven because we don't have the data to make those decisions, or at least the Category 1 data. Additionally, many, and in some cases, most patients aren't even represented by clinical trials. So how do we answer not just the questions that are answered by data, but those pressing clinical questions that are not? So going way back to 2013, the Institute of Medicine had published a report focused on how advances in medicine could be more rapidly implemented into clinical practice. And in that report, it discussed this information paradox, where you have a huge volume of data that was impossible for any clinician to read, process, and apply. But at the same time, that huge volume of data did not sufficiently address pressing clinical questions. And that's where the information paradox comes in, where you're simultaneously confronted with both too much and too little information to make the best decisions in treating our patients. So that takes me to prediction number 2, and this is the one that I focused my career on making a reality. That is that for unknown knowledge, that AI would bring the collective wisdom, physician wisdom, to the point of care. Okay, so MedNet has served as a digital hallway for over 10 years now, capturing the informal peer-to-peer clinical reasoning of physicians. And that's that knowledge that's shared in hallway conversations or insights that are exchanged between community and academic physicians. It's that practical wisdom that never really makes into journal articles, is presented at the conferences. You can think of MedNet as a living repository of how expert clinicians actually think, adapt, and make decisions when they're facing complex real-world patients. Today, there's over 40,000 physicians in 22 specialties, including over 3,400 experts who've answered questions. Another way to think of it is synthesizing the science and the art of medicine, the guidelines, the research papers, the trials, with the expert reasoning. So we can walk through like a very common sort of clinical situation. A patient with advanced breast cancer who's eligible for adjuvant CDK4/6 inhibitor. So how does oncologists choose between abemaciclib and ribociclib? Two drugs that were studied prospectively in patient populations that somewhat overlapped, but not entirely. You've got one drug that's twice daily dosing, and the other is once a day on a 3-week on, 1 week off schedule. One is a 2-year duration, one is a 3-year duration. One has a primary AE of diarrhea, the other one neutropenia. One you can use with tamoxifen, and the other one you can't because of the cardiovascular risks. So this is why we built MedNet. These are the questions in the gray areas of oncology where we traditionally seek expert insight. In addition, you're able to survey the oncology community on the practices. So you have, this sort of long-form expert responses discussing clinical reasoning in how to approach a question, and then a survey of, in this case, 250 oncologists talking about what they actually do and why. And there's over 20,000 Q&A like this on the MedNet across 22 specialties. So now this kind of brings us to how do we combine this collective wisdom with an AI? And in all honesty, we weren't sure when we start to think about this. The idea of using AI to answer questions where the knowledge is known was something that we had been doing, thinking about and actually doing research in for years before the emergence of LLMs. But what do we do when we want to also bring in that knowledge that's not known? So we started from a few principles, which is preserving nuance. We wanted to create a system where, that wouldn't just give a definitive and confident answer that when one didn't exist. We also wanted to allow for disagreement and surface those points of difference, because that in itself is incredibly valuable knowledge for a clinician trying to make a decision. We want to be transparent and show clearly who's being said by whom and why. And then lastly, and most importantly, we wanted to create a system that would say, I don't know, because often in medicine, that is the answer. And we know that AI systems are remarkably confident to the point of hallucination. So this is the result. MedNet AI launched about a month ago, and it combines guidelines, literature, and the experience, wisdom, and clinical reasoning of expert physicians. You can see that same question about adjuvant CDK4/6 inhibitors. with a clinical summary that talks about the prospective data, the guidelines, NCCN guidelines, ASCO guidelines, and brings in the clinical reasoning of experts as well. Additionally, the AI also recommends clinical trials by recognizing the question, the answers, and the context of the patient case, and then matching that with an appropriate clinical trial recommendation. This is actually part of an NCI-funded study, and it's available on MedNet as of last week. All right, and then prediction number 3. So this is the one where I was actually least comfortable with, that the physician's role would shift from an acquirer of information to an interpreter and a caregiver. And now that we live in this post-LLM world, I think, more clearly articulate much better why I felt uncomfortable at that time than I do now. So taking a step back, AI is absorbing the administrative burden of medicine. Documentation, prior authorization, inbox management, they're all being automated with a real impact on time spent on administrative work and after hours work, and an impact on patient satisfaction and burnout reduction. But there really is no comparable data on how AI knowledge tools, which physicians are using every day, how it reduces cognitive burden, that information overload problem that we spoke about. There is some data in the general population. This is a study of almost 700 individuals in the UK among various age groups, educational backgrounds, and professional fields. And they did this mixed method study, qualitative analysis, a quantitative study as well, when they were looking at AI use, cognitive offloading, and critical thinking. And higher AI tool usage was associated with reduced critical thinking skills. So, as a physician, what are the types of cognitive challenges that we want to offload? We entered medicine not just for the patient care, but because we like cognitive challenges. Physicians tend to enjoy solving hard problems. And critical thinking is really that large part of the satisfaction that comes with the practice of medicine. It's not just sort of about what we want to do with our jobs, but it's about the skills that a physician has. So more and more, especially among medical education circles, there's this fear of AI de-skilling, mis-skilling, and never skilling physicians. And the questions that are being asked currently is that, can the use of AI among physicians, especially trainees, result in doctors who are maybe super efficient, but really not as capable of independent problem solving and critical thinking than their pre-AI counterparts? And will this offloading of complex tasks like clinical reasoning and decision making, is it going to lead to the loss of previously acquired skills, which is de-skilling, failure to develop essential competencies, which is known as never skilling, and reinforcement of incorrect behavior due to AI errors, and that's been called mis-skilling. And really the key to avoiding these is critical thinking, both before and during AI use. So this is a paper that was published in New England Journal of Medicine a couple months ago and circulated widely in the medical education circles. But these stars represent a break in clinical practice for physicians of various skills. So you've got your novice, your advanced physician, the competent, physicians who've graduated, your proficient physicians, and then the experts. And so this break in routine practice is when you're seeing something you've never seen before. And so the way that the study, this sort of outline describes it, is that for an expert, the critical thinking starts before the generative AI is introduced, but also after. And using the AI to kind of have this AI enhanced adaptive practice, perhaps using it to learn about things that you didn't know about, maybe find out about clinical trials that you weren't aware of. But it's the combination of both using the AI, but also thinking critically about the results, about what you're learning, that leads to actually higher skills. And I would call that, what did I call it? Upskilling physicians. And that risk of not having that critical thinking is what leads to that de-skilling and the mis-skilling and the never skilling that's talked about. Okay, so what's the next frontier, right? And I think it's really scaling clinical wisdom and upskilling physicians. I don't think upskilling is a word anyone's using, but you heard it here first. So AI should support clinical reasoning rather than substituting clinical reasoning. Experts and educators need to actually model that critical thinking to their trainees to teach that lifelong adaptive practice. And then physicians, as lifelong learners, through AI, they can get exposure to summarized evidence, but also the skills to apply that knowledge to their practice, to their patients, from the collective wisdom and the experience of physicians. So in interacting with an AI system, you're learning the evidence, you're learning the guidelines, you're reading the published literature or summaries of it, but you're also being exposed to experts that you ordinarily wouldn't be exposed to. Individuals in different institutions around the country who are talking about how they think through clinical problems, what they do or the approaches that make them change their thinking. And I think the result of that is this upskilling, where you're actually becoming a better critical thinker because you're learning how to think. And that was one of the biggest things that you learn in training from your attendings and your mentors, is not just facts and what to do, but how to think through difficult cases. And so that's the future that I imagine, an AI where you could learn the known data, and then the areas where there is not, unknown information, where it does require, all of medicine requires a higher level of critical thinking. You're learning how to do that from experts and from faculty and experienced physicians that you ordinarily wouldn't have exposure to. And so this is just kind of like an example of a meta AI summary I was looking at yesterday, where you've got this, expert response, and then physicians who don't know, this expert saying, "Oh, that's a great summary. In fact, I learned so much from you. Thank you." And that's a feature that I'm very excited about as a physician. So, and that's it. Thanks so much.
Just a wonderful talk. Thank you so much, Nadine. It's incredible what you're building. So thanks for being a pioneer in that space, especially in our field. Tip of the cap. I think it's incredible.
Thank you.
You bet.
Yes, that was truly great educational tool, and it will only continue to grow. We'll leave the questions towards the end.
Our next speaker is Dr. Soma Sengupta. Hi, Soma, if you want to put yourself on camera. Dr. Sengupta is a nationally recognized neuro-oncologist at Tufts with a distinguished career in translational brain tumor research and clinical care. Her work spans molecular therapeutics, tumor microenvironment, and increasingly the integration of AI into neuro-oncology workflows. Dr. Sengupta brings a comprehensive perspective on how AI is reshaping diagnosis, treatment planning, and longitudinal care, with a focus on improving outcomes and personalizing therapy for patients with central nervous system malignancies. Welcome, Soma. Thank you so much for joining us today.
Thank you for the invitation. Greatly appreciated. We've already heard a number of talks that are specialized in the AI brain tumor space. This is an overview with a focus then on patient quality of life tools. So these are my disclosures, and I wanted to start with somebody that I helped take care of when I was at Cambridge. So his quote, Stephen Hawking, says, "AI is likely to be either the best or worst thing to happen to humanity," which is an interesting thought. So in terms of the overview, it's understanding the common AI terms and definitions, understanding the history of AI and its role in oncology, exploring the role of AI in oncology, gaining insights into how AI is transforming cancer research and treatment, examining its clinical development impacts, especially in design, execution, and analysis of oncology clinical trials. We've heard about the cancer diagnostic side, and then AI applications in drug discovery, and then some additional perspectives. So if we think about this, when we look at the volume and complexity of the data that's being generated, whether it's, one wants to refer to the AI, machine learning, or deep learning components of it, we sort of are almost overwhelmed by the data opportunities that we can generate. And then there's the additional perspective of generative versus agentic AI. And, there's constant sort of communication regarding whether we should be creating new content or using AI to take action and guide us, which was something that one of the speakers had brought up today and was in the question panel. And so I think that when we think about this, AI is a big umbrella, and machine learning is basically how the machines are learning from data that we feed into it. And deep learning it's interesting as a neuroscientist to think of the deep neural networks that are being generated here. And I have used the generative AI mode quite a lot, and I will go into it later. And then there's the agentic AI piece, which is continually in development as well. And then thinking about data privacy, HIPAA. So one of the primary challenges is protecting patient data, and AI systems require large amounts of data to function effectively, which often includes sensitive personal health information. And ensuring that this data is securely stored and transmitted and that patient privacy is maintained is imperative. Unauthorized access, data breaches, and misuse of data are significant concerns that need to be addressed. Then there's the ethical use of AI. There have been quite a few news media stories recently about the inappropriate use of AI images and people have thought that they were real people, and especially the younger generation when they're following them on TikTok or other social media platforms. AI can generate very lifelike images now. So there are ethical implications of AI in oncology. AI algorithms can sometimes produce biased results if they're trained on biased data sets, leading to disparities in healthcare. Additionally, the decision-making processes of some AI systems are not easily explainable, raising questions about accountability and trust. And AI needs to be used in a way that has the best interest of the patient and that patients have control over their data. In terms of workflow integration, we have to make sure that when we are interfacing AI into clinical workflows, that we cross-check the information that is in our notes. And then there's a whole area of regulatory compliance. So when we're thinking about AI transforming cancer care, we've heard a number of talks today already, whether we're thinking of cancer prediction mechanisms or surveillance, cancer screening, and diagnosis, but patient input is very important. So being transparent to the patient that there is going to be AI. So reiterating this slide again. So when we think of cancer prediction algorithms and surveillance and screening, cancer diagnosis, which we've discussed in prior talks, therapy guidance, we really have to think about how we're using all of this regarding clinician input and regulatory guidance. And also, when we're using all these inputs, we're looking at cancer response assessments too. So in terms of screening for neuro-oncology clinical trials, and this can be applied to other areas of oncology, of course, we're analyzing electronic health records. I mean, most of us are using Epic these days. And AI algorithms can scan through vast amounts of patient data, including medical history, diagnosis, lab results, medication records, to identify individuals who meet the specific criteria for a clinical trial. And in addition, we often send our patient tumors off for sequencing. So NGS data could also be analyzed, and AI can pinpoint patients with relevant genetic profiles that align with a particular clinical trial. And that makes things much faster in terms of locating suitable participants. But then again, think about the HIPAA breach here. And then the interpretation of clinical notes. AI can take an unstructured clinical note, and those of us who see patients with second and third opinions and have to go through basically a PhD thesis, it's really nice to have AI summarize things, but you still need to cross-check the data that it's interpreting. And it'll also keep flagging up study enrollment targets, which can be useful, but sometimes it can be misleading. So AI in healthcare, we've discussed quite a few different aspects. So you'll hear of IBM Watson, Amazon, PathAI, Google Health, Microsoft, Augmedix, Butterfly Networks, Arterist, Atomwise, and the list is kind of endless. And why do we need AI in healthcare? So those of us who deal with colleagues and, I have to deal with a department where physician burnout is a reality, patient volume and access is a constant, struggle, and then improvement of in terms of data interpretation. That's also another issue. So AI can help navigate these things for a clinician. So, for example, if you have a whole set of patients that require access, you can ask it to triage, and you can program it to detect the ones that need more rapid access than others. So why AI in healthcare? Patient satisfaction. Again, news media outlets, a lot of patients are using AI to even self-diagnose themselves. And there are cases of, misdiagnoses that patients then report that AI diagnosed them. And the converse is also true. Hoping that physicians and allied healthcare professionals have more time to spend with patients. Also, quality of life assessments and quality of life tools, which currently CRCs often do, but if AI can be integrated into these during a clinic visit, it would be much more rapid. And then documentation, there's AI-driven power scribes, and there are many options here, and many of the hospital systems that in the US are deploying either homegrown versions of this or ones that are available in the market. So cancer diagnostics, pathology was discussed, surgery was discussed, imaging was discussed, multi-omics data integration, and then liquid biopsies, another area, and clinical decision supports. So imaging, the other areas that it can help is positioning the patient. So when we're there looking at the MRI and wishing that the patient was positioned the same way as the prior MRI, well, an AI tool is available that can do that. It can also help plan the imaging exam, because sometimes we actually don't need all the sequences we use, and then we could reduce healthcare costs and the financial toxicity to patients. And it can automate the triage workflows. And we also heard about the tumor quantification and characterization of anatomy and abnormalities. And what's also interesting is that it can deploy convolutional neural network algorithms utilizing deep learning technology to interpret complex images. And we've heard about the surgical navigational systems. Pathology, I'm not going to belabor this, but there is a lot of use and excitement in this area. Electronic medical records. So this, I've worked with XCures previously, and it's a real-time health data platform which integrates NGS data and health records, and you can really do a lot of data mining in a short period of time. NGS data sequencing is also being linked to AI, and that could open up more rational drug development. For example, Illumina uses AI software to predict disease-causing genetic mutations in patients. The clinical trial aspect, which as a neuro-oncologist I'm interested in, it would be nice to have more fluid search engines look for appropriate clinical trials for oncologic conditions. In the US, clinicaltrials.gov is used, but it's not necessarily as patient-friendly as one would like. Antidote Match can connect patients to the correct clinical trials that they want, and AI Cure helps clinical trial sites and patients to participate efficiently for trials. Clario, which has a number of technologies, helps endpoint analysis of trials. So very useful here. In terms of looking for clinical trials, again, there's a huge list. Here are a few. You might have heard of the metadata solutions, cloud-based software, Clinidata, which can clean up the noise of clinical data for normalization and analysis, Deep 6 AI, which can enhance patient recruitment, Sama Technologies, which have algorithms to analyze clinical data, optimizing trial operations from patient recruitment to data management and regulatory compliance, which is huge. AI Cures H-Code, which is the world's first patient engagement AI. And it's a comprehensive platform that extends the reach of the care team and clinical trial participants. So here in a nutshell are 7 ways that AI can help in a clinical trial and healthcare setting. So we could potentially accelerate clinical trials. We could identify targets and validate them. And then we could predict and model drug properties, and we could optimize drug dosing, because a lot of trials have X amount of drug. Can we optimize it more efficiently? Preclinical testing models. We talked about the AI twin system, processing genomic data and identifying potential side effects before they've even happened. So in terms of quality of life applications, I've been working with a group of engineers who have an expertise in AI at the University of Cincinnati. So Professor Anand is the director of the Siemens Institute for Simulation, and his grad student, Manish Aryal, and Claudia Rabola is an industrial designer and associate dean at DAP, University of Cincinnati. So one of the tools we've been working on and interfacing AI with is an art therapy tool that we've just finished testing, the digital component of it. So it's actually quite painstaking to do each step, because you have to design it, then try it out on students, and then have an IRB to try it out on patients. And then once you're happy that the digital component works, then you interface it with AI. And it's to have the AI components, you have to have text image-based AI assistants and image-based AI assistants. And you combine it with a chatbot so that patients can interact with it. and also with DALL-E, so you can create images that you like. And so the AI-assisted art co-creation, you could have AI images based on prompts, but in the art can AI, so the art therapy version, the AI actively modifies user drawings in real time according to what the user wants. And then in terms of emotional AI feedback, the AI provides text-based responses only in existing tools, but in the art therapy tool that we created, it can analyze art, interpret emotional cues, and offer art-based feedback. Personalized AI avatars, in terms of what's available, users receive generic AI-generated art, whereas in the art therapy-based tool, it can generate user-specified avatars based on user input and feedback. And then the multilingual accessibility is limited language in current tools, whereas our current tool uses multiple languages and is kind of fluent in English and Spanish, and we're expanding its capacity. So what we're planning to do with this tool is we've applied for a National Endowment of the Arts grant in art therapy and digital and AI applications. So that's another funding mechanism that's available for AI and quality of life metrics is the National Endowment of the Arts. And we're hoping to run a study in adults and young adolescents and young adult survivors of various cancers and using this sort of art therapy AI tool. And we use a licensed art therapist actually to make sure that things are working correctly as well. So we don't, completely rely on this. So in terms of AI for patients and caregivers, I'm involved with these kind of tools as well with my collaborator, Jason Binder, who's a patient advocate, caregiver, but he's an AI expert. He used to work for AstraZeneca in the drug development arena, and basically understanding how the standard of care works, staying on track with things, interacting with patient support groups through the chatbot mechanisms, and offering personalized support geared towards the treatments that the patients have, and then spotting risks early. So for example, drug-drug interactions, if somebody's on supplements and they shouldn't be on that supplement with the therapy that they're on. So working on these areas as well. So moving along to oversight. So really, in terms of a governing body, a full board has oversight of AI utilized to drive strategy. You could nominate a governance committee, a compensation committee, an audit committee, and a huge important part of this is risk AI technology committee, making sure that these are in place even before you start deploying a lot of these tools. So in terms of ethical implications in medical diagnosis and treatment, there is a whole ethical side. I mentioned the transparency and accountability measures, but there's also the legal side, and it varies from country to country, and it could vary from state to state. Okay, so the sort of laws around the use of AI are constantly evolving, and it's something that we need to make sure that we're aware of when we're deploying tools. So with that, I wanted to acknowledge Doug Flora, who kind of inspired me on this journey. I did an MIT Healthcare in AI course and certification in it, which I found very helpful. And of course, my institution and OncoDaily for highlighting some of the work I do in this space. And with that, thank you for listening.
Oh, that was such a good talk. Thank you so much. The directions of all these applications are so phenomenal. I've got a couple questions for you, but we'll wait until the panel discussion.
Thank you.
Yeah, no, thank you, Soma. That was just great. Moving on to our final speaker of the morning, Dr. Benjamin Kahn. He is a radiation oncologist and physician scientist at Mass General, where he focuses on the development and clinical implementation of artificial intelligence in oncology. His work has been instrumental in advancing AI-driven biomarkers and integrating machine learning into standardized response frameworks, such as the response assessment in pediatric neuro-oncology. Dr. Kahn is at the forefront of defining how AI can enhance reproducibility, precision, and scalability in neuro-oncology trials and clinical care. Today he's giving a talk entitled Bringing AI to the Response Assessment in Pediatric Neuro-Oncology. Where are we and where are we going? Welcome, Ben. Thanks so much for joining us. We appreciate you.
Thank you so much for having me. It's really a privilege to speak with all these really amazing speakers, and I've been enjoying the talks throughout the day. Well, thanks so much for having me again. Really a pleasure to speak here today. I'm going to be talking about our work in trying to move AI tools into kind of clinical prime time for the response assessment of pediatric brain tumors through an initiative called AI RAPNO, which was spun out of the RAPNO working group, which is, also kind of the pediatric version of the RANO working group, which I'm sure many of you are familiar with. Okay, these are my disclosures. So just some background about myself. My lab is embedded within what's called the Artificial Intelligence and Medicine program at Mass General Brigham and Harvard Medical School. And I'm just really fortunate to have such a great group of collaborators under the leadership of Dr. Hugo Artz, who is a pioneer in the field of radiomics. We have a collection of clinicians primarily, as well as machine learning engineers, data scientists, and PhDs and postdoctoral fellows in various disciplines that kind of come through the program. Myself, I'm a radiation oncologist, but I have an engineering background, and my lab is devoted to computational imaging tools and AI applied to cancer imaging with a focus in pediatric brain tumors. So I'll start the talk by talking about, why do we need AI in RAPNO? What are the motivations for that? And then we'll go into kind of the current state where we're at now and where we'd like to be and how we want to get there. So RAPNO, as many of you know, kind of spun out of a need to develop standardized tumor-specific consensus criteria for assessing treatment response in children with central nervous system tumors. And so that outcomes can be measured in a consistent and comparable way. And so prior to these efforts, both RANO and RAPNO, there was really no standardized way to conduct response assessment kind of during, after treatment and into surveillance. So this was really a huge advance in the field to really start to codify and document kind of standard consensus guidelines for how to do this. There have been a series of papers published on this, which also just highlights the heterogeneity that we deal with in pediatric brain tumors with so many different histologies that require really separate guidelines to kind of measure what we think is most clinically indicative of response and prognostic for our patients. And then most recently, we led an effort to think about how we can better integrate AI and to really improve response assessment by addressing some of the pitfalls that exist. So the current challenges with guidelines like RAPNO and RANO, I mean, despite them being large steps forward, is there's still a lot of subjectivity in how we conduct response assessments. This is a typical readout from a RAPNO guideline for DIPG, and what we essentially have, which is pretty analogous to these different disease site guidelines, is we have these response definitions: complete response, partial response. Sometimes there's a minor response, stable disease, progressive disease. These cutoffs of generally 25% decrease or increase have been proposed as what is going to define these different kind of tiers of response. And the instructions are generally to find the longest diameter axis on any of the three commonly used planes, axial, sagittal, coronal. Find the largest perpendicular axis to that and measure those two and calculate the cross-sectional area. And that is what's used to then determine, did you meet this 25%, 50%, and so on and so forth. So clearly, when radiologists and clinicians are doing this manually, there's just a lot of room for subjectivity. And this was a slide lifted from the RAPNO meeting in 2025 that kind of highlighted, particularly for these diffuse or non-spherical tumors, there are just many different ways you could decide to draw this axis. And this is really only in one plane. And this would all kind of give you different results. So, there can be heterogeneity in what sequence is picked to do the measurement, the plane of measurement that's chosen, which slice has the largest cross-sectional area, the longest axis, and then actually just manually annotating that axis when you're, under time pressure, or, it just depending on kind of what the workflow is like at your institution, could lead to some arbitrariness. And then beyond that arbitrariness, the arbitrariness of this threshold being picked, it's kind of recognized in the field that this was just kind of historically based, this 25%. And that these tools, while again, a huge advance for the field from what was being done before, are still largely based in practicality and not centric to biology and how tumors actually behave. So, we hypothesize, and there's a lot of interest with all these AI tools that we've heard about today, and in particular, a lot of imaging-based tools. Can we do better, and can we more accurately really assess what's going on with a tumor when we're evaluating therapies, or when we have patients in surveillance for follow-up? So there is emerging evidence that 3D segmentation, which is a huge use case for AI these days, does show better stability and inter-rater agreement than these 2D measurements, and that also might correlate more with clinical prognosis and clinically meaningful endpoints. There's also the ability to do three-dimensional tumor subcompartment measurements, which can be really important when we're trying to assess how tumors are responding or what types of post-treatment changes we're seeing, things like radionecrosis or other types of post-treatment findings. And then it could also really make longitudinal tracking and looking at subtle differences over long periods of time. It could make it a lot more practical if we had tools that could help extract that information for us without having to do kind of manual review of all of these things. So just a few to kind of structure this a little bit more. I think 3D segmentation, likely, I think it's very plausible that this more closely represents true tumor biology, true cellular growth in 3 dimensions, rather than a 2D cross-sectional area picked in one plane. And that our ability to measure this accurately could lead to more precision and standardization of how we look at response assessment, both in clinic and clinical trials, and could give us stronger associations with treatment effect and how we evaluate treatments, clinical progression, and survival. And then a piece that I'll talk a little bit more about in the forthcoming slides is moving beyond just kind of what we can see and what we can segment with the eye, but to kind of understanding signal that's going on within the MRI, within the tumor and around the tumor, that might make for a predictive biomarker of how this tumor is going to either relapse or regress on a particular therapy. And kind of all of this boils down to, with all this information, we could more early identify or predict a change that's going to occur in a tumor, which could provoke a therapeutic action and ultimately help a patient. So kind of broadly speaking, it's a lot of the work that we are interested in my lab and some of the others in this space is, can we go from what's on the left, a kind of manual subjective interpretation of what we're seeing, to overlaying rich quantitative information that's AI extracted, that both provides clinically meaningful information from the scan you're currently looking at, but can also provide forward-looking information predicting outcomes with various treatment strategies. So these are kind of the lofty goals, and where are we now? So AI segmentation models for pediatric brain tumors do very well right now, particularly on baseline scans, so pre-treatment diagnostic scans. And a lot of that success has been driven by, both advances in the field, growing interest from different research groups and from industry, and these competitions that you may have heard of, called the BRATS competitions that are run out of the Mackay organization. So there's been a pediatric specific challenge. The adult challenge has been going on for, I think over a decade now, but for pediatrics, over the last 5 years or so, there's been a growing interest in developing pediatric specific tools because the adult tools tend to not perform very well in these heterogeneous pediatric settings. So what we're finding now, and these are results from the 2023 challenge, which is the last one that's kind of been fully published, but the DICE scores, which are the measure of overlap between the AI predicted segmentation and the segmentation that a radiologist or a clinician would segment, are generally above 0.8, in that kind of 0.8 or 0.9 range, so 80 to 90% overlap, which is, if you look at studies, generally on par with what inter-rater variability is between two experts anyway. So kind of hitting the ceiling of what we could expect to achieve with an AI tool. But there are notable areas that lag behind, and one is in enhancing tumor. We see performance universally dip in that regard, and as well as common failure modes that we see come up repeatedly in different studies. So I think the kind of biggest one being post-treatment changes, and particularly post-operative segmentation, remains a really big challenge, just because we don't have a lot of data sets to train algorithms for in this setting. And it's also just an area of more ambiguity, even as a clinician looking at the scan. Treatment-related edema, things like radionecrosis, differentiating that from tumor, and then certainly artifact, whether it's metal artifact or a shunt or motion artifact. These are all kind of common failure modes of AI. So, and these are areas that require further work and development, but also we just need to be cognizant of these failure modes when we roll out AI in the clinical setting. Some of our work has looked at this in particular for pediatric low-grade gliomas. We developed a model to segment pediatric low-grade gliomas using T2-weighted imaging, and we conducted a randomized study of 3 expert reviewers who provided their own segmentations of these tumors, completely blinded to each other, and then were presented in this randomized study with 3 different segmentations, and those segmentations were a mix of either 2 AI-generated segmentations and 1 clinician, or 2 clinicians and 1 AI, kind of shuffled together. And they were asked to rate the quality of these segmentations, where a segmentation score of 7 or greater was deemed kind of sufficient or clinically acceptable for a volumetric calculation. And what we found is, in the technique that we use to develop our algorithm, which is this AITE, so we use kind of a self-supervised transfer learning approach. The algorithm's performance was basically on par with the clinicians, and sometimes exceeded that. Sometimes clinicians preferred the AI compared to their colleagues' segmentation, essentially. And on average, that's what we were seeing. And then that's what you see in the top panel. In the lower panel, this is kind of the Turing test. So was the segmentation generated by AI? And when we used this advanced model, it was actually more likely for a reviewer to think that their colleague's segmentation was AI generated than the AI model. So this provided, I think, good reassurance and motivation that at least in the diagnostic setting, these tools are performing very well. And so what can we then do with that? Well, it opens up a lot of doors for investigation. And one thing that we were interested in is, now that we have a tool that we think is accurate, at least in the preoperative setting, can we apply this at scale to learn more about how tumor trajectories evolve for low-grade gliomas? One use case and one scenario in low-grade gliomas, sometimes these are found incidentally. If a child has a biking accident, or comes in with a headache for some other reason, they do an MRI and a small tumor is found somewhere, or a tumor that looks kind of indolent, kind of classic low-grade features, and then they're followed. And a model like this now allows us to study at scale what actually happens and what does the trajectory look like for those tumors, and provide some more information that just would have been very impractical to kind of gather, with manual segmentations. So this was a study looking at about 100 patients that were found incidentally with these suspected low-grade gliomas. And we just wanted to first assess, what percent of these progressed, what percent would eventually require treatment, and what the patterns of growth looked like. And so we found that about half of the patients progressed, and about a quarter were stable, and a quarter actually regressed. And we were also able to kind of explore different risk factors and associations for each of these different groups, which I direct you to in the paper if you're interested in learning more. But essentially, it was a good use case for kind of a practical use of AI to study patterns of growth and growth kinetics that wouldn't have been possible otherwise. And it enables us to also then calculate these individualized patient trajectories with volumetrics that could be helpful on an individual basis if you're monitoring a patient and you want to know, looking back, sometimes these patients have dozens of scans and you kind of really want to get a sense of, what is happening with this tumor. This provides a way to do that. And so then, we took this a step further and took this software and developed it into an AI-driven visual dashboard for pediatric glioma analysis. And so what this does is you can kind of choose the segmentation model that you want, depending on what population you're looking at, and there are dozens of them out there. And then you can put in longitudinal imaging, and it will calculate the volumetrics based on the segmentation. And then it will also calculate an automated RAPNO assessment of that tumor. And so for the case of glioma, which is the primary case we've been investigating, that goes back to some of those guidelines I showed in the beginning where you're taking the algorithm will take that segmentation, it will find the longest axis in one of those 3 dimensions, calculate that dimension, find the perpendicular, calculate the cross-sectional area, and then it will do that longitudinally over time. And with that, and then providing it kind of the rules of RAPNO, it will then also make a call of progression, partial response, complete response, so on and so forth. And so we developed this tool, and then what we've been using it for now with work that's under review is evaluating this in the context of pediatric clinical trials of different experimental therapies. So PNOC 008 and PNOC 002, Pediatric Neuro-Oncology Consortium, which are mostly institutional trials of different investigational treatments. We are looking to see basically what are the implications of using an AI automated workflow compared to what was actually what was done and documented on central radiology review. And so some interesting findings kind of came out of this. And one is that overall, we looked at the ICC, so the interclass correlation coefficient, which looked at the AI auto-RAPNO measure area and compared it to the central radiologist review. And we found that agreement was modest, so it generally clustered around the right area, but there were some outliers. And overall it was 0.7, which is moderate. When we looked at took a deeper look at see what was going on here and why it wasn't better than that, what we found was really interesting in that, but maybe intuitive looking back, that radiologists almost always use the axial plane for measurement in these trials on central review. Despite, by RAPNO definition, you really should be trying to find the longest axis on any plane. But for whether it's for comfort, practicality, or whatnot, it was almost exclusively measured in the axial plane. And a large part of those differences came from the fact that AI was identifying, based on that 3D segmentation, that there was a longer axis in the coronal plane or a longer axis in the sagittal plane. When we fixed the AI plane of measurement to the radiologist, that ICC went up. And specifically for pontine tumors, so things like DIPG, and tumors that also had high sphericity. So once you kind of narrowed in on tumors that were in the pons and that were very spherical, you really started to see excellent agreement. But it gives us a sense of where are the areas we need to look out for when we're and what are the implications if we were going to roll out AI in a trial, and start to think about how we're going to actually integrate this into something that's complementary to radiologist assessment. This is some data from the trials, and we would see things like with nice spherical tumors with kind of clear patterns of growth. The trends between AI and radiologists would track very nicely. But in others, sometimes they would track directionally, but the AI, which here is in red and green, would show kind of larger relative increases than the radiologist's assessment. So here, this would actually result in a different call. The AI would have called progression here, radiologist would have called stable disease here. And then, and occasionally we would find, an actual discordance where the radiologist measurement went down and the AI measurement went up. So it's just, it adds a lot of really interesting data that we're starting to analyze. And I think there'll be a lot more interesting findings that come from work like this. So I mentioned before going beyond volumetrics, and I think that's a real kind of, at the heart of the value of AI, in that potentially it can learn to identify imaging signatures of tumor that we can't really appreciate very well with the human eye by analyzing very large quantities of data and then kind of patterns of progression in the future. So in this study, we looked at preoperative imaging for low-grade gliomas to try to predict if we could to try to better predict who was going to have short-term relapse, which we defined as relapse within 3 years of surgery. Currently, that represents about 30-ish% of the population that has this type of relapse, and there aren't great biomarkers or clinical factors, I should say, besides surgical resection, which is clearly important. There aren't a lot of great clinical factors that help kind of risk stratify patients. So we thought that perhaps using these quantitative imaging features, we could do better. So we integrated deep learning derived imaging features into a risk stratification model and found that if you were to only use kind of the known clinical risk factors, including BRAF mutational status, and tried to stratify patients into low and high risk groups, you got some stratification. But if you layered those imaging features on top of the clinical features, which is what's shown on the right here, you could identify a subgroup of patients that had 92% progression-free survival at 3 years versus 31%. So I think, we did have an external validation set. I think this requires further validation, to see if it's really generalizable. But potentially, if you were able to identify this kind of cohort with a degree of certainty, that would be an ideal patient population to think about adjuvant therapy, or at least much closer monitoring for. We also have a really great interest in going beyond single time point prediction. Now with these newer AI techniques and architectures and computational resources, we actually have the ability to analyze longitudinal trends with deep learning. And so this was one of the first publications that we put out by a really brilliant PhD student, Divyanshu Tak, who devised an algorithm that first took a series of scans from a patient after surgery and first tasked the algorithm with putting those scans in the correct order. So it had to we basically would shuffle the scans and ask the algorithm, is this the correct order or not? And iterated on that thousands of times until the algorithm got as good as it could at putting those scans into the correct order. We hypothesized that by doing that, we were inherently teaching the algorithm to sort of recognize, scan to scan subtle changes and how tumors and tumor cavities kind of evolve over time. So we took that baseline knowledge and then we fine-tuned the algorithm to predict 1 year recurrence from the point of scan. So now we had an algorithm that you could input anywhere from, I think, 2 to essentially 12 scans, and it would analyze the scan trajectory and then predict, is this patient going to recur within the next year? We studied that across 4 different data sets, and we consistently found that by using this temporal learning approach, which is what we called it, you could improve the ability to predict that 1 year recurrence-free survival. We also found that, as you'd expect, as you give the algorithm more information and you feed it more scans, it is able to more accurately make those predictions to a point. And then it would kind of hit a plateau depending on the data set and the setting, somewhere around 4, 5, 6 scans or so. And so I think, what this then, the implications of this is that, a patient could come in, the algorithm could analyze the trajectory of scans in a low-grade glioma patient, and then give a prediction about, what's going to happen within the next year. If that prediction of recurrence is extremely high, again, maybe that implicates the team to take an action. And if it's very low over repeated years, like this bottom scan, these are the types of patients where maybe you want to space out surveillance. Maybe they don't need to have, every 3 to 6 month scans. These patients are often followed with these kind of uniform schedules for decade or more, the low-grade glioma patients. And so I think there's a real opportunity to do some personalization here, and that AI could have a role in that. Taking this kind of one step further, we were also, a huge problem with developing models for any type of pediatric brain tumor application is that we're dealing with limited data sets. And so there's been a lot of interest in development of foundation models, and the LLMs are the key, the prime example of these foundation models. But in imaging, there's also been a number of foundation models coming out. There had not been one for brain MRI. And so what this essentially does is it takes a large volume of unlabeled brain imaging, and in our case, it was about 50,000 scans, and we basically have the algorithm kind of self-train on that unlabeled data with various tasks. So, one task is to basically crop and augment the image, and then ask it if the image is looking at if you compare two kind of augmented scans and say, is this coming from the same scan or not? That's called contrastive learning. There's also a way you can kind of patch out parts of a scan and then ask the scan to recreate that patch, within itself. And by doing these tasks on unlabeled data, you're intrinsically teaching the algorithm to learn about how brain MRIs are structured. So then when you again point it to a task like tumor segmentation, IDH mutation classification, even things like dementia, brain age, the kind of possibilities are endless here. You still need some data to train those tasks on, but you need a lot less data than you would have needed if you were going to train a model from scratch. And that's what we showed in this paper. We think there's a lot of potential uses for technology like this in the brain MRI space. So this gives a glimpse about kind of where we are now. But I still think there's a lot of work to do, and I'll try to cover this in the next 5 minutes. But essentially, what this comes down to is how we cross this translational gap. We have a lot of models. We have, an ever-increasing number of them, and we need these models to improve in performance overall. However, for the models that are already very high performing, we still have a big problem in that we need to really show that these are valid across different populations. We need to make them usable and make sure that clinicians, they fit into the workflow, that they're interpretable. And we need to, I think most importantly, is make sure that they have clinical utility. So, in the case of 3D volumetrics, I think, we still need to investigate whether or not integrating this technology is actually going to improve patient outcome and decision making. So it's kind of the question of, yeah, we can do it now, but should we actually use this technology in that setting? And then there's a lot of pediatric specific challenges for AI and RAPNO. I don't think it's just like the little brother to AI and RANO, which there's also a huge need for that. But there are specific things that make this space, I think, particularly challenging. One is the biologic and histopathologic heterogeneity that I mentioned, with just all the different histologies that are very different from posterior fossa tumors to gliomas to germ cell tumors and other things like that. The data is particularly scarce. These are rare tumors, so we're dealing with siloed data, usually from single institutions. There's a few exceptions to that, and this probably is the biggest challenge we face in pediatric brain tumor AI, is collecting and aggregating and harmonizing data. We also know that these children, where we have models for children from infancy through young adulthood, and these brains are developing in very different ways. And so there are a lot of under-recognized effects of developing brain and how that confounds our ability to make these predictions. And I think that's an area we need to explore more. And then there's also a lot of acquisition protocol heterogeneity, a lot of artifact. A lot of these patients have things like shunts or EVDs. And there are particular survivorship and late effect concerns, I think, that we need to be thinking about. So with all that in mind, we formed this AI RAPNO initiative. It's led by Drs. Kazaruni and Nabavizadeh within the CHOP ecosystem. And then there's 4 of us that are kind of have leadership on different steering committees. But the mission is to promote the safe, effective, and clinically meaningful translation of AI tools for response assessment in pediatric neuro-oncology, ensuring these technologies enhance clinical expertise in the care of children with brain tumors. And we have over 50 participating members from around the world now, and encourage anyone interested to join up with the group. We just had our first scientific exchange meeting this morning. And so it's built around aligning these tools with clinical need, building community consensus from AI experts, and bringing AI experts and radiologists and neuro-oncologists together to figure out what the best path forward is for integration, and then publishing recommendations and guidelines. And so we have a number of things that we're looking at in the mission here on the right, and I refer you to these papers that were published in the fall if you're interested in seeing more details. I think in the interest of time, I'm just going to kind of go through these next slides very quickly, but 3 of the focus areas we have right now are in benchmarking, in infrastructure, and then, as I mentioned, in scientific exchange. When we talk about benchmarking, this is something that I'm heavily involved in. It's kind of, you're in clinic or you're designing a trial, you want to integrate AI into that trial. Which model do you use? There are dozens of them, and that's a good thing. It's also a bad thing because you don't know, which one is going to best serve your population. So there's a real need to have clinical benchmarks in various clinical contexts that we can then benchmark different models on and figure out what is going to be the best model for this particular population that's going to give me the most accurate results. And so we're designing now, what the current standard is now. I guess I should say where we want to go is an iterative approach to benchmarking, where we have models, data sets, and metrics, and we can have fluid evaluation over time. So as a new model is developed, we can benchmark it in real time against a particular population that we're interested in. What we have now is the BRATS competition, I think, is the best example of benchmarking. And there's some real strengths to this in that it's very rigorously annotated. There's multi-institutional data. There's a lot of oversight. It's very transparent, and it's a very fair process for submission. But it is static, and it is only, currently, it only involves high-grade glioma patients. And so what we're envisioning is kind of a more a public validation leaderboard that's hosted on AWS, and that kind of allows for what I discussed is like iterative model evaluation and benchmarking. This is being led by a PhD student of mine named John, who is designing this kind of dynamic interactive leaderboard where you can look at different cuts of data. So here, if you wanted to see the results of a particular model on just DMG and medulloblastoma, it will compare 4 different models, and it will tell you things about how fast did they make their predictions, what are the subgroups that they're performing better or worse on, and can give you a sense of which model is going to be the best for your clinical problem. So in summary, I think AI-driven analysis of longitudinal imaging will improve the accuracy and reproducibility of response assessment in pediatric brain tumors, including earlier prediction of recurrence. Advances in performance gains are positioning AI tools at the cusp of clinical translation in pediatric gliomas, and there are notable challenges that remain, particularly failure modes in the surgical and post-treatment settings and other types of pitfalls. And the AI RAPNO initiative was formed to help address these challenges of translation and to promote safe implementation of reproducible AI in clinical trials and practice. And with that, I'd like to thank this really just amazing group of collaborators from across the country that have helped with this research, and my great lab students as well. And I'm happy to take questions and looking forward to the discussion.
Just a great talk. Thank you so much. It's just incredible where that's heading towards. So I'd like to invite all of our second half of the day panelists to join us back on camera again if they're able, and we'll open up the floor to questions for this segment of our symposium. For the members that are still on as attendees, please know that the chat function remains available. If there are questions for our panelists, please don't hesitate to write those in there, and we'll make sure those get asked. I'd like to start just with a question for Nadine. What do you see, Nadine, as the most important factors in building clinician trust in using AI tools designed for real-world oncology decisions? Dr. Day and I were talking that at least the general population, I think 1 in 4 people are utilizing AI. I'm not certain if we have data that that physicians are of that same quantity. But curious about what your thoughts are on how you see that evolving.
Yeah, I had mentioned the AMA data that reported about 81% of physicians in the US are using AI, and that's increased pretty quickly since they first started collecting that data back in 2023. In terms of trust, it always comes back to knowing the source of the information that's provided. And so the first one is obviously for the literature is having citations. And that's sort of like now a no-brainer because any like medical AI platform will provide citations. When integrating the community into that is the trust comes from knowing who's saying what. So if you've seen MedNet, there's nothing that's anonymous. Right? It's not like a Reddit, it's your name, your institution, your profile, what you've published. And so I think those two, it really comes down to like knowing the source and then critically analyzing that source. There's no piece of data or no individual who's above any sort of critique. Any phase 3 randomized trial that's published in the New England Journal of Medicine is definitely worthy of critique. So.
Fair. Yeah, very fair. Thank you. Yeah, there's one question online here. Jack Sharman's joining us online. Question for Dr. Sengupta, or the rest of the panel, actually. Wondering if you could talk about HIPAA regulations in this new data environment where Google or Meta have an incredible amount of personal data on us already without our consent. Is HIPAA needlessly restricting or already being circumvented by these companies? So we as academic institutions are stuck in slow compliance. Great question, Jack.
What I will say is that there is a law AI tracker, and you can actually see what the law allows in your state. So each state has a different variation of it. So for example, California has a whole slew of laws. So even to the point of, if you're using AI to generate images and anything you do, you have to have that. Whereas Massachusetts in the AI tracker has one law. So you really have to go through on a state-by-state basis. And regarding HIPAA, even though Meta has an incredible amount of personal data about us, unfortunately, the healthcare systems have not evolved beyond the HIPAA regulations yet. And I say yet because I think it's only a matter of time that will evolve as well.
Great, thank you.
I have the same point for primarily the clinicians and the patients are using AI. So how do we kind of keep their trust and be seen as a partner, not as a replacement? Because there are studies that AI is more empathetical towards patients than physicians are. And that's why a lot of people kind of using it as an alternative to primary care, not as a supplement to primary care. how do we overcome that and not be seen as a either or?
I'm happy to take that one. So basically, what I would say is that we can't really, we can't in this era say that we're not going to deploy AI. So I think it's meeting the patient where they're at. And if they're very tech savvy, to understand what data sets and what inputs have been fed to the tool that they're using. So for example, I know of a GBM chatbot that is operating globally now and has resources from over 24 countries in there. And, you know, so the amount of information that a patient can acquire is enormous. You know, so to say, you know, what you have is not the way it should be, but what I'm saying is the way it is. I think we have to become more conversant with what's out there.
Yeah, I would just chime in and agree. I think AI has come so far. I remember an era where, you know, it was first starting out, patients would come and say, "Oh, I Googled this," and like, you know, what do you think? The universal response is, "Don't Google anything. You know, it's all garbage out there. Like, don't." I kind of poo-pooed a little bit, but I think with now the tools are actually really good, and I think you have to be able to read through like if they present to you something that AI has kind of told them. I think you need to really be able to digest it, reason with it, and then explain why or why not you would agree, or, you know, kind of where the nuance is and where you depart from what the AI has said, particularly with these things like open evidence and some of the like health related apps that are out there.
So
I also like
sorry, go ahead.
There's just traditionally been this imbalance of information between physicians and patients, and that imbalance is becoming less because of the access they have to basically the same data sources that we do, with an interpretation which might look very similar to the way that we interpret it. So I would approach patients honestly with curiosity, because like sometimes you can learn from the patient themselves. But even the most educated patients who will come to you with PubMed articles in hand are still going to ask you, what would you do for your family member? And I've seen that multiple times. So what they're looking for isn't always just like knowledge, it's interpretation and advice. And we have the skills to do that.
That's fair. Ben, to springboard on a comment that you just made, you know, just with it's very true. The tools are becoming that good, you know, specific to the work that you're doing in RAPNO, and, you know, even tools that we use with our clinical trials group for, you know, a dedicated quantitative imaging lab in order to help with assessments, as opposed to relying upon, you know, either community radiologists or just radiologists that may not have training in this. What needs to happen, or what's your vision of the future for these tools actually becoming the accepted response assessment tool for use as opposed to clinicians?
Yeah, I'm still of the mind that these are going to be complementary tools. I mean, in that it's not going to replace. I think, you know, unless we're talking about the real distant future, but I think that there are enough pitfalls currently. I mean, I think there's going to need to be a role for human oversight, and it's going to be kind of like the human is going to need to sign off and review, you know, what the AI has done, and kind of like we've said with these, you know, LLMs with patient, you know, responses, or, you know, with other information, it's going to have to kind of contend with what the AI has put out and say, you know, maybe this is kind of right, or maybe it's not, you know, or this something about this is suspicious. I do still think it's going to be this kind of partnership between the clinician and the AI, and still see it as a tool that they'll use.
Yeah, thank you. Any other questions? Yeah.
There's a question up there.
Oh, Sam's got a question here. Here, let me pull this up. Dr. Bob Holtz had a question for the entire panel, or clinicians on the panel. How often does a patient's AI use detrimentally impact care, or conversations surrounding care?
So on the neuro-onc side, for adult neuro-onc, I can tell you that if a patient has received a synopsis through some of the AI chatbot tools for brain tumor care, and they ask them about repurposed medications and also supplements, ivermectin often comes up. So then I spend about 15 minutes going through the data with them as to why I wouldn't use it in this setting. So, but you know, there are some excellent suggestions there too. But that's one of the ones that I can think of.
Just try not to direct him to the Joe Rogan podcast. So, you know.
Yeah, exactly.
I've actually started calling it the Mel Gibson effect. Because I've noticed ever since Mel Gibson did that interview on Joe Rogan, you have people coming in asking about ivermectin, methylene blue, you know, what the medical establishment is keeping from the general population. And I had a few patients make really bad sort of decisions in terms of what they were going to do. And I've termed it being Mel Gibsoned.
That's funny. Any other questions for our panel today?
I just want to add that there's like there's no technology that's like all good or all bad. It's really how you use it. And it's been like that, you know, since the emergence of the internet, right? You could have a patient, you know, even forget about AI coming, can asking about ivermectin just because it's on social media, it's on the internet. I know someone who was highly educated and declined cancer care for curable cancer because of a video she saw on YouTube. On the other hand, you have patients who are coming to you and asking, hey, I was reading about this cancer and it said that I should ask my doctor if there's clinical trials available for me. So it's, unfortunately, nothing is all good or all bad. But I think the best way to approach it without kind of like losing a patient is really like this approach of like, well, tell me more about that. If you can give me the literature, I'm happy to look at it and go through it with you. And sort of explain sort of, maybe you know something that I don't know, or maybe I can see different ways in which the data, there's a reason why I wouldn't apply this data for your care. So.
Yeah, that's fair, Nadine. Thank you so much.
And just to piggyback on that, I think all of you who are creating new models and training new models, there's so many ways to go. There's just so many data, so many ways to go. So how do you decide like which question is worth pursuing, or which part of this AI algorithm needs more data that I should, you know, feed it more versus what is just a distraction, or like how do you navigate that thinking to decide what's going to move the field and what's just a shiny distraction?
I mean, I usually, it's challenging. I think one thing I usually do is I try to really think hard and say, you know, would I use this in my clinic, you know, for the patient in front of me, and really be honest with myself in that question. I think that gets to the clinical utility piece where it's, you know, you could have something that, you know, has a really accurate assessment of X, Y, and Z, but is it of value enough that it's something that you would actually truly consider using? And a lot of things, a lot of cool ideas in my mind failed that test. And so I shelved those ideas. Even the ones that passed that test, sometimes later I shelved them, but you know, it's at least where I start.
Any other questions? Well, thank you all for joining us today. As mentioned throughout the morning, it's really truly been an outstanding session. And I think just showcasing not only the rapid evolution of AI and neuro-oncology, but you know, more importantly, the collaboration and thoughtfulness that's happening to translate these innovations into meaningful improvements in patients' care. The discussions today just absolutely reinforce that while the technology is advancing quickly, it's the integration into clinical workflows, the trust we build with our patients and our colleagues, and the focus on patient-centered outcomes that will ultimately define success of these tools. Thanks to the speakers, especially those that have stuck around all day, for your time and expertise and energy that you brought to this conference. It's really, truly been amazing and eye-opening for me. Dr. Day and I are in here playing with some of the tools actually that you guys had highlighted in your talks, and it's just been eye-opening for us as well. Before we close, I just want to encourage everyone who's online still to please complete the evaluation form that will be sent out to you following the completion of our symposium. Your feedback is really incredibly important for our planning committee. Dr. Day, Dr. Morris, Dr. Krukoff, and myself, we really take that into consideration for what will be the next iteration of our symposium this fall. And for the participants that are still on, thank you so much for your engagement today and your great questions that you posted online. Definitely looking forward to continuing conversations with everyone here, and definitely we'll see you at future events. I'm sure snow is, well, 6 months away probably, right? So yeah, very good. But we'll close our session. Dr. Day, anything to add?
No, thank you all for your time and you generously spent your morning with us, educating us. And I learned a lot. We were just playing here with all the tools that you guys were saying. So I was learning as you guys were talking, and that I thought was amazing.
All right.
Thank you, everyone.
Thank you so much. We'll close our session. Appreciate you guys.
Thank you.
Thank you.
You bet. Bye-bye now.